today, the 9th of December 2021. Welcome to members of the public and press who are joining us either here at New Shire Hall in Auchenbury or who are joining us online. A reminder, our meeting is live streamed through the County Council's YouTube site and is recorded and will be on the Council's website following the meeting taking place. To remind members of the public and others that filming and photography is fully permissible in the meeting as long as it doesn't disrupt the proceedings. Can I ask everyone to make sure your mobile phone is on silent or vibrate while the meeting is taking place? As ever, the toilets, including the accessible toilet, are in the corridor to the left as I sit. There will, I hope, be a comfort break during the course of the morning, if at all possible. After 2 hours. There's no fire alarm expected today, so if the fire alarm does sound, the meeting will be immediately adjourned. We all make our way downstairs and meet at the green opposite. And I should say I'm Councillor Richard Howard. I didn't introduce myself. In terms of item 1, we've got one apology for absence, and that's from Councillor Jerry Bird. I think most people will know this, but it's the first meeting we've had since Councillor Bird had a serious personal health experience, which led her to being treated in hospital. She's now recovering, and I'm sure on behalf of all of the committee, we want to send our very, very best wishes to Jerry Bird for a speedy recovery and hope that we see her back before too long. Thank you to Councillor Goodliffe, who's here today and who is substituting for Councillor Bird. Councillor Goodliffe, of course, is the chair of the Children's and Young People's Committee, and we have joint responsibility on health with your committee leading on children's health. So I think it's very good that you're here personally to observe how we deal with the health issues, and just to put on record for all the other members that we coordinate closely on the health issues, and I'm very grateful for the cooperation that we have together. I'd also like to welcome Councillor Howell as a new member of the committee. Councillor Goldsack has stood down. We thank him for his service, but as I think I observed at the council meeting, Councillor Howell has clearly got a keen personal interest and experience in some of the issues that we deal with in this committee. So I warmly welcome him and look forward to his contributions to our debates in the time ahead. Can I next ask if any member wishes to declare any disclosable pecuniary interest or non-pecuniary statutory disclosable interest? And I have one, please, Councillor Wilson.
Thank you, Chair. Just for the benefit of everybody, my wife, Sarah Wilson, who's joining us this afternoon for the health scrutiny as a District Council of Huntingdonshire, works in one of the mass vaccination centres.
Thank you, that's noted. Any others? No? Next, I'd like to congratulate Charlotte on my left. Charlotte has been appointed in the interim since our last meeting to be the interim or acting, I'm sorry if I haven't got the words quite right, Executive Director of People and Communities when Wendy Ogle-Wellborn steps down in the new year. I'd want to congratulate Charlotte. We don't lose her from this committee. She's still going to carry on with the role of Director of Adult Social Services in title, although one of her assistant directors, our assistant directors, Debbie McQuaid, is going to be stepping up to take the day-to-day responsibilities that Charlotte does for us. We wish Charlotte well in that post. Look forward to continuing to work with her as closely, and it is obviously a recognition of the high esteem that we feel for you and the work that you do for this authority. I think there will be further occasions in the council when we'll want to thank Wendy as well. She's obviously not here at the moment, but I would want to place on record our thanks to her for all of the work that she's done, and perhaps that could be passed back to her through you. And am I allowed to say who's the stepping up person? I said one of the assistant directors.
Debbie McQuaid.
Am I allowed to say it though? I am allowed to say it. Debbie McQuaid has been appointed to do that stepping up role. So I just wanted to check that I hadn't gone ahead of myself by saying that. And she's a very experienced member of the team already, and someone that you'll see at this committee and we'll look forward to working with. So thank you very much. There's one other prior bit of business that I will just explain at the beginning. You'll have seen from an email from Democratic Services yesterday that an urgent decision has been added to the committee agenda. That was sent to all of us by email yesterday and is already published on the council's website, and it's on the allocation of infection control, rapid testing, vaccination and workforce recruitment and retention funding in response to the COVID-19 pandemic. This is the first time we've had such an urgent item since I've been the chair, so I've checked carefully the procedure with our colleagues, with Tamar and our colleagues in Democratic Services, and I will just explain it for other new members who are not aware of the procedure. The Constitution allows for an urgent item to be added to an agenda which has been published if it meets the urgency criteria set down in the Constitution. As the chair of the committee, I've received this explanation, and it's for the following reasons. Firstly, the council needs to be able to respond quickly where failure to do so would not be in the public interest. Secondly, the procedure for taking urgent decisions is being used because failure to take the decision quickly would be likely to harm the interests of the council and the public. And in this case, the grounds are a service not being provided and the public putting at serious risk of harm. And this is all to do with the extra money for COVID infection that's come from government and that we quickly want to disperse that. The substance of that will be explained later in the meeting. But I've authorised the inclusion, or myself and the Vice Chair have authorised the inclusion of this urgent report so that members of the committee can take the decision. It will be taken after item 9 on the agenda. So I just wanted to explain that at the beginning because it's a slight late change to the agenda, and I hope that's satisfactory for all members. Now let's move to item 2, which is the minutes of the meeting that held on the 14th of October. And the action log accompanying that. We're being asked to approve the minutes of the meeting as an accurate record. They're on pages 5 to 10 of the agenda pack. Any questions on the accuracy of the minutes? No objections, so we'll take them as carried unanimously. Do I have to sign something? Yes, which is one there, and then I'll pass it to you. Yeah, please.
Could I highlight one important typo, please? I'm sorry to come in late.
A little louder. If you could bring it
Sorry, Chair. May I highlight one typo, please? I believe this is on pages aren't numbered. I think it's page 3. The bullet point that starts discussed the caring together proposal. I believe that should say care together. Is that right? It's the ways in which neighborhoods could be enabled to support individuals to remain in their own homes. So I'm quite sure that's care together. So if we could just correct that for the minutes to be clear. Thank you.
I'm receiving nods to my right. Any other questions on the accuracy? Thank you for that. Councillor Van de Ven, I pass those minutes to Tamar, and that's the minutes done. An updated action log was included in the published papers for this meeting at pages 12 to 14 of the agenda pack. Are there any questions on this? No, we'll take it as noted then, with thanks. Item 3, we've got no petitions or public questions. So we'll move immediately to item 4, strategic issues. The first one is the update on the enhanced response area status for COVID-19. It's on pages 15 to 22 of the agenda pack. And can I ask Jyoti Attry, our Director of Public Health, to present the report, please?
Thank you, Chair. Excuse me. What you have before you is an early evaluation of our ERA status. It's really difficult to draw hard conclusions from what we have presented there, because that was only conducted only 2 or 3 weeks into the ERA being operational for our area. We did it at that time, though, because we were being asked whether we would want to extend our ERA status for longer than we had. It was originally given to us until the 5th of December. So in terms of data, it's very difficult to tell whether it's had an impact on infection rates because infection rates aren't static. They're moving up and down at different rates within our patch and across the country. And we have no real comparators no controls to compare ourselves against. So I don't think we'll ever be able to know whether it's actually made a difference to infection rates. I think where we have seen a measurable difference is in school vaccinations, and we did want to use the status to speed up vaccination coverage overall, including in our schools. And at the beginning of the ERA status, we were below the national average. We are now at the top end of the spectrum. So I think that's one success we can count against the ERA. In terms of the measures that we used were threefold. One was around vaccinations, which I've talked about, and we've drawn down an incredible amount of national resource in the form of the Surge Rapid Response Team to target areas of low vaccination coverage, and that work is ongoing. We had hoped to look at before and after vaccination rates, so weekend events where the Surge Rapid Response Team were here to drive up vaccination coverage and after. However, the announcements around Omicron have led to significantly increased access to vaccination coverage. So it's difficult to determine the impact that the SRT has had in that context. I think the other area where the interventions have been particularly valued are in schools, and the fact that the interventions have been used in at least 50 schools demonstrates the value that head teachers and schools place on the interventions, and they have indeed reported that they do particularly value the interventions available to them. As we've moved towards the period where we were required to put in an extension, the government issued some extensions themselves, and some of the measures that we put in schools around face coverings in communal spaces and reduced on-site visits were implemented nationally by the government. So we were then required to consider whether we would get additional value from being an ERA over and above what was available to us in any case. And there were a couple of interventions that were not part of the national interventions or available to us through the contingency framework that's used to manage COVID in schools. That was only available to us as part of our ERA status, and they were local contact tracing and LFT testing in primary schools in the context of outbreaks. And we felt that they were valuable. The head teachers valued those interventions. And we still had some ongoing Surge Rapid Response Team resource available to us. So for those reasons, we did apply for an extension, and the fact that our vaccination coverage is lower in parts than the national average. So for the combination of those reasons, we did decide to extend our application, and we have in fact been granted an extension covering us till the 24th of December. Almost as soon as this is written, we're in a very dynamic situation, as you're all aware. The world has changed. Rates of Delta are very high across our patch and rising. We have Cambridge, Huntingdonshire and South Cambs with rates higher of Delta than they have ever been. They are the highest they have ever been in the history of the pandemic. So this is still quite a precarious situation for us. The rates are largely driven at the moment by the school age population and are increasing in the primary school age population. Thankfully, rates in over 60s, in the history of this pandemic, when rates have risen for all ages, there's been a corresponding increase a week or two later in the over 60s. We're not seeing that at the moment. Rates in the over 60s are remaining below 150 per 100,000 at a district level. And I hope that's indicative of the impact of the booster in preventing infections as well as severe outcomes and hospitalizations and deaths. Although I would say there's a need for caution in that, because rates are largely circulating in our younger population. And there will be increased mixing across generations as we head towards Christmas. So I think there's still a need for caution. I say that because the attention in the media is all on Omicron. We still have a large degree of danger posed to us from Delta. And of course, Omicron adds to those risks. In terms of what I know, there's definitely higher transmissibility associated with Omicron. A doubling rate of 2 to 3 days is being quoted. Everything else pretty much that you see in the press is largely speculative. We're still waiting for the lab work to be, the lab research to be carried out in terms of vaccine escape. And we really won't know fully its impact until it's been circulating in our population for a month or two. The fact that it's more transmissible increases risk alone, because that means that more vulnerable people are likely to be exposed, and we know they are more likely to have adverse outcomes. So the higher transmissibility alone causes me concern. I think we're heading towards a very difficult period over the next couple of months with both Omicron and Delta in the mix.
Thanks very much. I want to say a couple of words myself at the start of the debate. One is, I think I want to really place sincere thanks to you, Jyoti, and the public health team for not just everything you've done in the pandemic, of course, but also for spotting this early and being decisive on acting on it when we appreciated a month and a little more ago that there was a real local challenge that required extra local action, hence the enhanced response area status. And I remember you saying at the time that you feared that we in Cambridgeshire were ahead of where the rest of the country would be. And although I think Omicron has complicated it, as you've said, I think a lot of what you said has turned out to be correct. And I think although we don't want to over-claim anything, I think the differences that we're seeing in the schools, we wouldn't have seen without enhanced response area status. And the fact that we're the only authority anywhere in the United Kingdom who has got an enhanced response area status and got it extended is a real tribute to you and the public health team, I think, for your decisiveness and being bold in trying to protect local people during the course of the pandemic. And I want to place my sincere thanks to you and your colleagues for that. I think with Councillor Goodliffe here, it's good also just to highlight the excellent contribution there's been with schools. And I know you'll want to, I think you know it already, but also pass that back to all your colleagues in the Children and Young People's Committee. I also want to place a record my thanks that I think when the first case of Omicron we became aware of, the health service became aware of on Wednesday of last week, within a day, you'd informed all the actors that needed to know internally, and together we'd made that public so the public can have confidence and trust that information is being made available to them as soon as possible to show that certainly as far as our authority is concerned, that we can and should be trusted for doing, as I said at the time, everything we can at every point. Two final points. I get a lot of inquiries about difficulties in getting access to vaccinations. At the same time, we're really trying to boost the message and strengthen the message about vaccinations. I know that the length of queues sometimes and changes to schedules sometimes have caused some inconveniences, but I've discussed that closely with our public health team, and I believe that the capacity is there today. No one should be daunted today from seeking a vaccination. The opposite, we want them to do it. The capacity is there today, and the focus is on getting the capacity right for the surge that nationally has been announced, and we I'm sure support for the future. And finally, what we say in every time we discuss this, the same measures are the ones that need to take place. Get the vaccination, wash your hands, practice social distancing, wear the mask, you know, and I think we just have to say that every time to make sure that message consistently gets through to the public. I don't normally speak at the start of debates very often, but I feel very strongly about that, and also I've been privileged to be part of the discussions with the public health team, and I wanted to say those words at the beginning of the debate. Next, Councillor Slatter, please.
Thank you, Chair. I wanted to do a congratulations, you've done that for me. So I have, but I also did want to reassure Jyoti. She talks about an unknown impact on infection, and of course that is the case. And we would be foolish to chase certainty in this matter. On the other hand, this extension of the enhanced response and the firm attitude being taken by the Public Health Department of the County Council is of immense value for the morale of people, the public. And so to thank you on behalf of them, you know, the mothers who are trying to get their kids to do the right thing, the shops that are trying to get their customers to do the right thing, the public spaces like our lovely community centre, where now we can show it's a safe space. Anybody looking in the windows can see people are wearing masks, they're obeying the rules. And this gives consistency at a time when there are so many mixed messages from other places, that it's good to have this firm message from New Shire Hall here. And so thank you for that. A couple of questions though. I'm afraid all 9 of my grandchildren have indeed had the infection. There were intervals, they have timed themselves, I'm glad to say. I see, if I understand it rightly, the vaccinations for children start at 12, but secondary school, of course, starts earlier than that for some. I don't know whether that is something from on high that you can't change. It would obviously make life a lot less complicated for people if they knew that secondary school children were going to get vaccinations. Who knows, it may have moved on by tomorrow afternoon. So that was one question. And the other one, I was pleased to see in Friday Focus that we are encouraging our staff, the County Council staff, to volunteer to be trained to vaccinate. And it was a question on whether we are also giving guidelines to others, larger employers, obviously, who may be wanting to follow suit, and to encourage people. It's not a very complex skill, even I can do it. So, I'm, you know, you just need a good attitude to people more than anything. So if you could just clear that up for me, thank you.
Thank you, Councillor Bowden, please.
Thank you, Chair. First of all, I'd just like to respond to a point that you made, if you don't mind, Chair, about the accessibility of booster vaccines in particular. And I have to say my experience was very good. It happened only last month, and at that time the rule was that you couldn't have your booster vaccine until at least 6 months, or I think it was 182 days after the second jab that you'd had. And the day before that 182nd day, I went onto the website, saw there was an opportunity to get the booster jab the next day, and was able to book myself in for 9:15 in the morning. So it's not universally the case that there is a problem. In many cases, there is accessibility, and it is important that people make use of that and are not deterred by the reports. And there are genuine reports, I accept, but they shouldn't be deterred by the reports that in some areas, particularly in London, there appear to be some difficulties in getting booster jabs and jabs 1 and 2 as well. They shouldn't be deterred from trying, because they may well find that they're successful in doing so. I'd like to thank the Director of Public Health for a calm and reasoned verbal report that she gave to us. And I have to say that I think that no good is done at all in our fight against COVID by people who go over the top in terms of fear, or who fail to appreciate the severity and the importance of the fight that we've got. And having that middle line of presenting the facts in a calm and reasoned way I think is by far the best way that we can manage to win over more individuals, get more individuals vaccinated, and make sure that more individuals follow all of the rules which you, Chair, mentioned before. We are, however, very much in a state, getting to a state of COVID fatigue, where many individuals are really getting quite fed up with the situation that we're in. And who can blame them? We've gone through 19 months of really, really difficult times. And we have to continue to get the message across in as positive a way as we can about the importance of following the advice which is given by public health, and especially of making sure that individuals are, if they're medically able to, are fully vaccinated and also receive their booster shot when it becomes available to them. And one of the ways in which I think that we could do this better, and I have copied you in on this correspondence, Chair, and I've been very grateful for the responses I've had from the Director of Public Health. One of the things which I think is really important is that we should have clearer and starker information being sent to the public so that the public can see what the facts are, not overblowing it, but saying just what the basic facts are, because the basic facts are really quite frightening in a way. The basic facts are that you may be 4 to 5 times more likely to be hospitalized if you're not vaccinated as opposed to being vaccinated. The basic facts are approximately, and the precision of numbers is something I know the Director of Public Health is concerned about quite correctly, but approximately you're 10 times more likely to die if you're not vaccinated as opposed to if you are vaccinated. Now, there are differences in terms of age profile, and numbers have to be normalized, and I fully understand that it becomes complicated, but it's really important that we get these stark messages out. I think over the weekend there was some publication of information from I believe it was the Midlands, where it was shown that overwhelmingly the vast majority of those individuals who are getting the most intensive care are unvaccinated, even though they now account for fewer than 20% of the population. And it's messages like that which we really need to get out. And I've been struck by some of the comments made by doctors and nurses who have given interviews or have written pieces saying how they have been moved beyond belief by unvaccinated individuals who find themselves in hospital, sometimes in intensive care, and who are then begging for to be vaccinated. Far too late, of course, but it's heart-rending to see these reports coming out, and quite how some of the health workers manage to contain themselves emotionally, I'm not at all sure. But it's dreadful, and the more that we can do in order to make sure that the facts get out there, the better. And the Director of Public Health, I know, has kindly sent me a proposed document which might be able to go out. We need something which is clear, straightforward, which people can understand very simply. I did copy you in, Chair, on what the Center for Disease Control in the US put out 2 months ago, which was very, very simple, but it got that message across that it really pays individuals to be vaccinated. It really is important both for the individual concerned and for society as a whole. And I would encourage us to use the extra funding, I believe, we get through our ERA status to be able to get messages across to the general population in as effective a way as it's possible to do. And if that means putting them up on billboards, on advertising hoardings, if it means even television adverts, whatever it may mean, let's get the truth out. Let's get the message across in an honest way with honest numbers which can be backed up. And that's why I so much welcome the approach that the Director of Public Health has taken. No scare stories have been coming out. What have been coming out have been the facts. And the facts are the strongest arguments that we've got. But there is one fact which worries me.
We are at time, so one more sentence. Sorry.
Okay, one fact which worries me. And I actually welcome the enhanced response area opportunities that we've already taken and will now be able to take until December the 24th. But I'm a little bit concerned that we are the only area to have now the advanced response area status. And I just wonder, is there a potential for a message which isn't accurate going out there? Because it's not as though this area, Cambridge and Peterborough, is the very worst in the country so far as infections are concerned. So I'm a little bit puzzled by, a little bit worried about the messaging about our being the only enhanced response area still in existence, even though I welcome the extra work which is being done. Thank you, Chair.
Yeah, thank you. Sorry to hurry up at the end. I certainly associate myself with the main points you were making, and thank you for making them. Last time I saw the figures at Adam Brooks, by very, very substantial proportion, the people in intensive care from COVID were people who are unvaccinated. So what you said nationally is also true locally to the very best of my knowledge. I'm sure the Director of Public Health will also respond at the end. We've got one more speaker and now I have closed the speakers list. It's Councillor Wilson, who's our final speaker, please.
Thank you, Chair. And just to reiterate Councillor Bowden's comments about mass vaccination centres, the experience for my wife is that if you're able to get a booking, then book it and then you don't have to queue. But a lot of people are dropping in because that's the advice that government is giving. And we had the case of the Guildhall in Cambridge where people were queuing around the block, taking 4 hours to get in. They were just so desperate to get their boosters that that's what they were prepared to do. The question I wanted to ask Jyoti was, at what stage do you think we should be making representations to government that we should be going back to holding meetings either as hybrid meetings or in virtual meetings? This afternoon, we've got a hybrid meeting with people joining us on the screen, which I think is ideal. And I think we should be considering that for our main meetings ourselves. Thank you.
Thank you very much, Jyoti.
Thank you. Ever so much there to respond to. I'll try and hit everything. Let me know if I miss anything. Children's Vax, we are bound by the Joint Committee of Vaccinations and Immunisations declarations on that issue. I believe they are actively considering lowering the vaccination age range, and when they do, we will implement that locally. Volunteering at the moment, I think they have more volunteers than they can cope with. They still need more. They've just got some logistical issues around getting the right people to the right vaccination centre, etc., and the right skill sets. We will continue to push to get more volunteers to support the vaccination campaign. I think there was that early bottleneck in terms of people queuing around the Guildhall, etc., that was in response to the government's announcements. The government did shortly after announce that you should wait until you're called. I think that wasn't heard as loudly as the initial call. But I think that situation has improved and people can access vaccination more easily than last weekend, for example. In terms of the information that you've requested, this is ever so difficult to get right. The balance between having messaging that's clear and easily understood, but accurate, is really difficult. And we've been asking UKHSA or PHE as they were for that support, because whatever applies nationally will apply locally, and we've not had it. Which I think demonstrates how hard it is to get right. We do know, part of the complicated factor is that as more of the population are vaccinated, you've got the paradox of the fact that will mean that more people in hospital with COVID have been vaccinated, because the vaccine is not 100% effective, and people who are vulnerable will still end up in hospital. And we're heading that, more people in hospital have been vaccinated. That's entirely expected. That is not vaccine failure. With regards to the presentation I shared with you around the infographic that we could put out, it has gone out to members and is about to go out on social media imminently. So there will be something available to people to understand the benefits of vaccination. We have already used patient stories, people who've ended up in hospital who haven't been vaccinated. That's been used in the press as part of our campaigns to increase vaccination. I think I've covered all of the questions.
Well, thank you very much. I think it's right that we dealt with this as the first substantive item on the agenda. Once again, sorry, you wanted to add
there was
something?
one more, sorry, around we're an ERA. Is that what you're going to come back on? So when we put in the initial application, we were towards the worst end of the spectrum in terms of rates. We also had particularly low vaccination coverage. We're probably not outliers. Rates of Delta are high across the country. but we're still lower in terms of vaccination coverage. And I think that was the justification for the extension. And actually, we just argued that we needed to finish what we'd started. We hadn't had the rest of the SRRT response that we had requested, and we still had further to go on vaccinations.
And I think, one, to thank you again, but to also put on record that when you make these applications, in each case, you've consulted widely, both within the authority, but also with our health partners and with other interests locally, and that there is broad support for this from across the community and community leaders. This isn't just an issue from within the authority. The recommendation that we've got, sorry.
Okay.
Okay.
Point the view about virtual meetings.
Apologies. I've just put out advice that all non-statutory, so non-council or committee meetings should move to virtual. I think if you wanted to make representations, now is the time to do it.
Could we collectively agree that that's what we want to do?
Can I just check that? There's no issues about that being put in the minutes. Is that okay? Yep. Okay. Does anyone disagree with Councillor Wilson's point on that? I will just incorporate that in terms of the minute of the meeting. And of course, it is a national decision that, and as I understand it, the Local Government Association has been pressing for this for some time, but there's some resistance in government. Hopefully that will be reviewed. The recommendation before us is to simply to provide support for the measures in place as an enhanced response area. Anyone against that? Can I take that by acclamation? I'm seeing lots of nods on all sides, so that is agreed. We're about 10 minutes behind on what is a very full schedule this morning, and this afternoon is completely timed in terms of the health guests joining us, and I don't want to lose the lunch hour, and neither do you. So I just asked people to, I think it was right that we allowed a very full debate on that item, but I just asked people to be concise on some of the rest of the business without wanting to close down discussion, of course. We next have item 5, adults self-assessment. It's on pages 23 to 64 of the agenda pack, and we're being joined online by Tina Hornsby, who's Head of Adults Performance and Strategic Development, and Tina is going to be presenting the report. Good morning, Tina.
Good morning. I have done a brief presentation for you, which I'll try and not take too long over because I know you're stretched for time, but just a bit of context. I'm coming today to present to you the findings of the self-assessment process, which is part of our sector-led improvement work we do regionally. You may be aware that the new white paper and the recent Health and Care Bill introduced future national assurance for local authority adult social care functions, but at the moment we have what we call a sector-led improvement programme where we do a self-assessment and we have various challenge sessions with our buddy councils and with an external director who is employed by ADAS to come and challenge us on our self-assessment and some of the things we say. The other thing that's recommended for local authorities as good practice is to publish a local public-facing view of the self-assessment, which is included at Appendix 1 for your sign-off and public before we publish even. I'm going to try now to share my screen and hope it doesn't go badly wrong. Okay, share. Now, are you seeing, I'm hoping you're seeing the local.
Yes, that's fine. That's nice and clear. Thank you.
Wonderful. I'm going to try and put it on present too, and let's. Okay. So the first slide is just a very brief overview of activity to give you a bit of a feel for how many people we have contact with. What I would say is we had slightly less people last year having sort of the basic contacts, technology and reablement than previous year, and slightly more people with long-term support. And I think that's really partly the impact of COVID and some of the changes to how people were interacting with wider health services during that time, and just people not wanting to come forward potentially where they would have done before. We'll come on to a very brief slide about COVID at the end. So we then sort of cover off how we spent our budget. So you'll see the vast majority, 75% of the budget is spent on purchase, care and support. And in terms of the split between client groups, it's the biggest spend is older people and learning disabilities, with smaller amounts for mental health and physical disabilities. We're asked to sort of reflect on our top achievements. Our reflections would be our response to COVID. We managed to apply some of our really good work that we've done around strengths-based practice into how we responded to COVID, sort of bringing in place lots of the sort of wider preventative stuff, but also we were able to establish a really good relationship with our community, our COVID hubs, and help them to direct people appropriately if they contacted them. We also did a lot of work supporting our care providers who, you know, were really heavily impacted by COVID. And I think we feel that our relationship was improved with them, and their feedback was very positive about the flow of information and support that they received. In terms of the top 3 risks and challenges which we're asked to identify, supporting people in their own homes is still a challenge. It was during COVID and during lockdowns, and it remains a challenge. We're seeing more complex cases presenting to us, reduced confidence and more frailty as well amongst our older population, and increased strain on carers, which is very real. People who work in social care have been under an unprecedented amount of pressure. We suspect, and we're starting to see evidence, that older workers are starting to choose to retire sooner, and there are obviously pressures around the care workforce that were there already that are just worsened. And our financial situation across the system is very difficult, with a very pressured local NHS. And also a lot of the funding that's come down during COVID has been of temporary nature, so it's hard to plan long term and more strategically in that environment. In the self-assessment, we cover our partnerships. Obviously, we cannot operate in isolation, and our key partnerships are with our health partners, and that's GPs, hospitals, and of course our learning disability specialists that actually are employed within the learning disability partnership under a Section 75 agreement. Public health, obviously, and we've had dedicated support from public health around our COVID response, and also some shared campaigns that have been really helpful for the preventative and early intervention aspect of our role. We have a Section 75 for social care delivery for mental health with CPFT, and we've got the Good Life service there as well, which is a sort of early intervention prevention model. We took over the running of the 0 to 25 service with children's social care. So now Adult Social Care hosts that service, which helps us with our transitions planning and our preparation for adulthood. We've got close relationships with our housing partners and a new housing related support strategy. And then there's been a vast amount of work with our voluntary and community sector. Care Together, I heard, was mentioned already from a discussion last committee, but we've also got other community projects such as Innovate and Cultivate, where we've had a lot of support for early intervention and prevention type innovation projects, a lot of men's sheds and digital support programs really aimed at early intervention and prevention for our client groups. Community engagement, we work very closely with Healthwatch. They actually support us in running our partnership boards and our Adult Social Care Forum. They did a lot of work with us during COVID as well around hospital discharge, and also did a survey for us around the impact of COVID on our clients. We also do work with Sun Network, Speak Out Council, and Counting Every Adult co-production groups. The Adult Social Care Outcomes Framework is the performance framework that Adult Social Care are judged against nationally. It's quite an old outcomes framework, if I'm honest. It predates the Care Act, and it doesn't necessarily reflect everything we'd want it to. It's currently being reviewed nationally, and we're expecting a new framework to come out in 2022. But for now, this is our sort of performance, the areas where we do better. They're sort of around the quality of life aspects, self-directed support, permanent admissions to care homes which are low, and people who successfully complete reablement with no long-term care and support needs. But there are some areas that we do less well on. People finding information and advice easily is one of those areas. The numbers of people receiving direct payments, learning disabilities supported in paid employment, and some of our reablement numbers leaving hospital. And then there's also the historical issue around delayed chances of care, which is actually now an indicator that is no longer reported. And there's just the final bit about the impact of COVID, really. So I referred at the beginning, COVID has had a big impact on how we deliver care. It's had an impact on how our service users are able to access informal support. It's had an impact on how they might be presenting to us. And I think it's true to say an impact on, indeed, the visibility of vulnerable adults. There was also some practical changes that that came around due to COVID. For example, we've had a change to our discharge pathways from hospital, with the discharge to assess process being introduced. We've had more sort of proactive work with family carers, with proactive contacts made during the first lockdown to develop what if plans if we didn't have them already in place. Obviously, a real change in the topic of conversation with providers, with lots of guidance around PPE, infection control, and the various financial support arrangements that have come through. And working with our local communities to try and connect into the community hubs, try and make sure the right messages are going out, and also some work we did with staff around how to have the right types of conversations with people. And then there's obviously the impact it's had on people, which within the report we detail, and also we go into a bit more detail of within the actual public facing local account about how actually people told us that COVID impacted them. And I think that was my final slide. So now I've got to try and get back to you and stop sharing my screen, which could be,
While you do that, Tina, I think we can start the debate. Thank you very much for that. Obviously, this is a process by which our officers review progress and challenges vis-a-vis colleagues elsewhere. It's obviously very useful to be reported to us to give us an overview of that, and what we've seen in terms of the slides are some of the key messages about that collectively we're reporting to the public. So I think this is a really important exercise. Councillor Slatter first, please.
Thank you, and thank you for the report. Very helpful, and thank you also for we got printouts as well, which I always like a bit of to jot things down and share with others. 2.3.5, you mentioned it just now, the transfer of children's social care. Clearly, that makes a great deal of sense, just like having health and social care so carefully coordinated as they are now. A quick tribute to the people who helped us have some training. Face to face, we were very fortunate, but socially distanced and a howling draft, you'll be glad to know. But no, it just opened my eyes to some of the detail, which one might have been able to imagine, but it's so much better to hear it from the people who are doing it. And to find that there's actually an OT in there, at a very crucial leader of the team. And I think that something like an occupational therapist, professionally qualified occupational therapist, is a symbol of health and social care integration, because they don't claim to know everything, but they know a great deal, and they know the details, and often the devil is in the detail. So what with that and the wraparound care, looking at families as a whole, I think we are definitely serving well as we can, acknowledge all the terrible pressures on your staff, and I know we all are very grateful for those who hold up. If some of the older experienced ones are getting a little weary, I sympathise, and if it's possible for them to have sort of staggered retirement without staggering too much, whatever ways we can keep their experience, I would hope we can, but we wish them well, because they are in a difficult time to be working in this area. And thank you very much for the training and giving time to us to help us understand. Thank you.
Thank you. Councillor Daunton, please. I think we've got someone here to help. So, oh yeah, perfect.
Okay, thanks. Yeah, doesn't seem to be working. I'd like, if you wouldn't mind commenting on page 28 of our agenda under 2.7.1, work with community catalysts to develop micro enterprises. If you could just talk a little bit about that, please.
Thank you. And the last speaker is Councillor Wilson.
Thank you, Chair. And I may have sort of worked it out in that I was concerned that there's quite a few places where we say we're doing less well than the regional average. And I was hoping that each individual one of those would have been picked up to indicate what we're doing as a result of it. But the answer might be, well, the key areas of focus in 2021-22 cover everything. So the question is, do they definitely cover everything? And then the second question is, on one of the slides, it shows that we have a score of 19.4, which is better than the regional average of 19.25, but it doesn't explain what the maximum might be or what the target might have been. And is that necessarily good or bad?
I think you're the chair of the audit committee, aren't you? And that question betrayed your expertise in that area. It's a very fair question. Though what I'd want to say before I hand it back to Tina, I really love this report showing the challenges and where we're below average as well as we're above average. It's just patently obvious that you can't be above average at everything. And so to recognise that, but to see where we might need to improve and then to build that into our thinking, I think is a really important part of the exercise. And I really, really liked it. Tina, to answer any of the questions you've heard, please.
Okay, I'm not mute, that's good. So I'm going to start with Community Catalysts, although Oliver might want to jump in too. So the Community Catalysts is a group that has expertise in supporting small businesses to set themselves up as micro enterprises, and we're particularly looking, our early pilot is around East Cambridgeshire, but we're particularly looking at supporting people to maybe become mini care agencies. So what we do have at the moment is the method for people to become a personal assistant, a self-employed personal assistant, and be employed by somebody. But the difficulties with that are kind of probably obvious. If you want to take holiday, what's the person that's employing you going to do? So one of the ideas that we've had to try and make care more local, and that's worked elsewhere, is that you look at having a group of individuals who might be interested in that type of role, working in a community that they live, who might want to group together and become a micro enterprise and support each other to deliver those kind of services. So that is in my non-involved nutshell way of explaining it. But Oliver's come on, so I'm hoping you might bail me out a little bit on that one.
Yeah, if I may just add to that. So the Community Catalysts are working with the local authority on our place-based approach in East Cambs, which we're calling Care Together. So Community Catalysts, as Tina quite rightly references, have been remarkably successful in other parts of the country, namely Devon, where they've done a huge amount of work in really building at a street level, local level, to enable a much greater choice and control for people around how they choose to take their care. Principally, it's around the provision of domiciliary care, and it adds to what is a really, really challenged marketplace, both from a PA, so personal assistant.
Shall I move on to the areas for development question? So yes, the areas of development cover most of the areas where we do less well, generally, because if we've identified them as an area for development, part of the reason may have been because a performance indicator suggested that being an issue. I guess the only one that I would say probably isn't covered in those would be around the learning disability and employment, where we have got a separate piece of work happening around the learning disability vision and the learning disability day services, which links to that actually we haven't set out specifically as that area for development in the report. And then the quality of life indicator, I smiled slightly because it is a slight mystery to even those of us that live in the performance world. But what it is there's an annual survey that takes place of service users, and it's people that receive long-term care and support. And in that survey, they ask a number of questions about someone's quality of life. And depending on the answers to those questions, they weight the questions between 1 and 5. And the maximum, if everyone's quality of life was extremely good in all areas, would be 25. Most local authorities perform between the late 18 point somethings and the late 19 point somethings. So we perform comparatively well compared to the region, and in fact comparatively well compared to many in the country. But there's always room to improve people's quality of life. but you'd never expect to get to 25, I would suggest.
Okay, is that everything, Tina?
I think that's everything I'd noted.
Yeah, great. So Councillor Wilson, if you and I both have a quality of life score of 19 out of 25, probably we'd both be happy, wouldn't we? So I thought that was a great answer. The recommendation we have is to note the findings of the self-assessment and approve the public-facing local account for publication. Is there anyone who wants to oppose or abstain on that? I'll take that as passed by acclamation. I didn't know, Oliver, you joined us at this point. You're hiding away. We can't see you on the screen now, but thank you very much. There we are, you come back. So thank you very much, and we'll be seeing you later, I think. Tina, I know that you worked hard on the whole process, but on the public-facing document as well, that you're involved with us with. Can I just say, give my personal thanks for that, and I think really it's outstanding. So thank you very, very much indeed.
Thank you.
We now move on to item 6, day opportunities for older people. It's on pages 65 to 80 of the agenda pack. Sarah Bai, who we know well from previous meetings, is unwell today. We wish her well. So Shauna Torrance, the head of Adult Social Care Commissioning, is stepping in to present this report on Sarah's behalf. Thanks for doing that, Shauna, and I now hand over to you.
Thanks, Chair. As has already been stated, this report is on day opportunities for older people and physical disabilities, and we are requesting approval to extend a number of grants for these day services at a total value of £1,338,620 over a 24-month period. Day opportunities are centres or hubs within local communities where people with support needs can go to meet others and receive welfare and wellbeing support. These services are currently delivered by 3 in-house day services and 25 grant-funded services, which are located at various points across the county within local communities. Over the last 18 months, the pandemic has had a significant impact on the delivery of day services and the ability of providers to continue to do this at full capacity, and continues to do so. The detail of this is in section 1.5 to 1.7. It's also had a huge impact on our ability to deliver planned commissioning activity around this, as the need to support these providers through the impact of the pandemic has been prioritised. Whilst the report has detailed work that has taken place to date around the transformation improvement of day services under 2.2 and 2.3, there is still quite a significant amount detailed in 2.4, is focused on working with local communities and users of the service to co-produce a new service design that is fit for purpose and meets their needs in the future. The extension requested will support the ability of the council to undertake this development in partnership with key stakeholders, but we've also built the flexibility into this extension to allow us to implement any solution earlier if appropriate and possible. Thank you very much.
Thank you very much. Councillor van der Ven, please.
Thank you very much for all the work on this report. I just wanted to ask if you could give us a sense of some of the learning that has taken place from the reopening of services that we might want to take into account when eventually things are retendered and perhaps new ways of working come on board. Thanks.
Thank you. Councillor Bowden, please.
Thank you, Chair. I will be voting in favour of this item, but I have to say that I have concerns. It's not merely about this item. And we're very fortunate, by chance really, that we have the Chair and Vice Chair of the Audit and Accounts Committee sitting as members of this committee as well. Because at the recent meeting a couple of weeks ago of the Audit and Accounts Committee, we finally received the 2017-2018 value for money report from our external auditors. And it made excoriating reading, to be quite honest, concerning our ability to follow our own procurement rules and even to follow procurement law properly. And it was a very worrying report, and I'm pleased to say that the chair of the Audit and Accounts Committee shared my concerns about that, and we will in that committee be taking action over the course of the next year to ensure that the issues which have been raised are addressed. But today we have 3 agenda items 6, 7 and 9, all of which are requesting further exemptions to our procurement rules to take place. And reasons are given in each case. We've just heard the reasons which have been given in this case, and we are where we are, and there is no choice, in my opinion, but to support what is being put forward. But we were warned by the head of procurement for CCC at the Audit and Accounts Committee meeting that using exemptions to allow extensions of contracts increases the risk that we are not going to be getting value for money. And we have to be very careful and cautious about leaving ourselves in a position where we are effectively forced to seek an exemption to allow an extension of a contract. For us to have 3 of them in front of us today is a very worrying sign indeed. And I will come back to that on future items. So I'm in favour of this. I understand why it's in front of us. I understand we've got no choice but to agree to this, but it is worrying that we're in this position, and we must beware of having too many requests to exempt ourselves from our own procurement rules, let alone potentially risk breaking the procurement law, which we'll come to at a later agenda item. Thank you, Chair.
Councillor Slatter, please.
Thank you, Chair. Thank you for the report. Clearly, the coronavirus pandemic has brought out some of the worst in the nastiness of pathogens and some of the best in our public and our ingenuity. And there are massive opportunities for developing the community hubs, and with it, the opportunities for day activities, and also looking down the list, things like the transport and making the best use of public money, of course. And there is obviously a massive amount to do in a short time. I was wanting to suggest, though it may well not be possible, but for both 6, 7 and 8, as Councillor Bowden has said, they have this common thread. When these come back, would it be possible to have our discussion as a confidential item? Because I find it quite awkward to know what one can actually say, with what names one can name, and yet one of our functions, I feel, as councillors and representatives of our local residents, is to bring in some of the local knowledge and even some of the local worries or the local ideas, and to make sure that we can chip in with questions about particular possible contractors that cause us concern, which obviously one would hope to raise ahead of time, but I think we need to raise it in this forum as well. So if it was possible, we had a bit of a flurry of this in children and young people, didn't we, in terms of there was a confidential item that we have to be very careful what we said because we were still in public forum. So if that would be possible, Mr. Chairman, I would really welcome that as a newbie, in that I hopefully wouldn't be saying the wrong thing with it on the record. Not that I was wanting to be deceptive, but there is obviously commercial concerns there. And otherwise, I just wanted to say thank you. There's a tremendous amount behind this report. I always like to read about Over Community Centre because it's a rival with Trumpington, because I have a relative over there. We think we're better and she thinks she is, but they're both very good and involve professionals and volunteers in such a good cooperation, and that's what we need. Thank you very much.
Thank you. I will comment on that myself at the end of the debate, but we've got one more speaker, who's Councillor Wilson, please.
Well, I share Councillor Slatter's concern that I would have expected these items to be considered in confidential session, particularly as we list the values and the names of the proposed contractors. I recognise that it's an extension, so maybe it's slightly different, but even so, I would have expected it to be confidential. I also share Councillor Bowden's concerns about the procurement rules being broken and EU law being, or UK law being broken. And I would just draw people's attentions to the bit that presumably has come from the head of procurement. Extending these agreements is not a compliant process within the contract procedure rules. I can understand the importance of doing it and the necessity for doing it, but it doesn't make me feel comfortable, particularly in having had the BDO report only a fortnight ago or a week ago, where we are yet again breaking our own procedures. So I will support this, out of necessity, but it doesn't make me happy doing it.
Okay, I think we've had two very important issues of principle raised during the course of that debate, so I want to make sure they're carefully responded to. Can we just take first Councillor Slatter's point? I will come back to you, Shauna, at the end, but I want to deal with those points of principle first in the room about confidentiality, reference to individual projects or people. I think that it's an important question because I think all of us as members should be free to speak about people and places that we represent. I often speak about individuals. I'd only ever do so with their consent, but and I never be complicit in personal details of any service user of our service being disclosed in any way in public. But I would hope we can speak as freely as possible in the course of these meetings, and it's in the public interest that we take these decisions in public. So I think there's also a counterbalancing argument there, and it's an interesting tension about how we enable both objectives to be fulfilled. I do say to all members that we all have an opportunity to write to or approach officers if we have individual concerns about any particular facility, service or person, and we all do it, and so that opportunity is always open to us. And the spokes meeting for the different party spokespeople are also an opportunity for us to raise cases in private with our officers. So if any member of the committee feels that they've got a concern like this, please speak with your party spokesperson, and that's another opportunity to do it. But I think it's such a fundamental question. I'd also like to ask Charlotte to comment, please.
Yes, understand the question. Understand the question, and we get I regularly get contacted by members about all sorts of issues, and we will always respond to them about individual cases and share an appropriate amount of information and be sensitive to information sharing issues. In terms of this particular issue, we wouldn't normally have a confidential. This is a sort of public decision that the committee is being asked to make, but we do provide briefings, pre-meeting briefings with obviously the chair and the vice chair and the opposition spokes. That's normally where those issues would surface, and sometimes further questions will follow on from that before the committee, but we wouldn't normally discuss something like this that is going to be made in decisions going to be made in public in private in a confidential session. I don't know whether, I think Will looks like he wants to say something.
Please.
Yeah, thank you. So I just want to mirror that. If so there's two parts to this. First part is we need to be as open and transparent about the providers that we're commissioning and the cost of that. I also think, and I would strongly encourage members that if there are concerns about providers or services that have been commissioned and feedback from those, that is fed through, as and when they arise. It's really valuable information for us, and we take it very seriously. So, my sort of request is don't wait. Just as it arises, please raise it, and you can send that to either Charlotte or I.
Thank you. Now on the just 30 seconds then, please, Councillor Wilson.
Fair enough.
I'm seeing Councillor Wilson's hand first, I think, but then it's 30 seconds each because we have closed the
I just
debate.
want to come back on something Charlotte said. I think there's a difference between making the decision in private and then publicising it. I think we can hold a confidential session in which we discuss whether or not it's appropriate to go to this list of individuals. And then once we've made that decision, yes or no, publicising it. But I would welcome the guidance of the monitoring officer or head of procurement or somebody about that. Thank you.
We'll note that in the minutes, if we may, Tamar. I'm inclined myself to keep it as in public as far as possible, but I think a question's been raised, so we'll minute that, and I'm sure that the vice chair and myself will further discuss this with the officers and with our members. Councillor Slatter.
Thank you. I will, as I said, I wouldn't expect to be ambushing officers or being, unhelpful like that. But there is a limit to what one can do in a series of emails or even through our spokespeople. And that does somewhat suggest that there's nothing to be gained from discussion in this committee. And yet I'm always learning from other people around this room. And I may even have something useful to say occasionally. And that should feed into the decision making. If otherwise it's all done by spokespeople and filters, and I'm not suggesting that Susan or you wouldn't pass things on, of course you would. But there is that sparking off a discussion and practical politics and local knowledge that I believe is valuable. And so if we can have some sort of combination of being able to talk about the details and compare notes, and then to be open with the public about the decision, and hopefully they will trust us that we have looked into the matter. If they don't, if they think that we are being muzzled, they will not trust us that we are being listened to on their behalf. That's what I'm concerned about.
I think the question has been very well aired, so I thank that, and I just further confirm Councillor Van de Ven and myself have heard that. It'll go in the minutes. We'll discuss it with our officers. There may be some sort of compromise area around perhaps members being asked, having the opportunity to ask for an item to be put into a confidential session, for example. But let's look at all of the options around the questions that have been raised rather than take an immediate decision on that. Secondly, the points raised by Councillor Bowden and Councillor Wilson on the exemptions. I might ask Will to comment on that in a second. My reaction to that is, first of all, let's not just repeat what was discussed at the Audit and Accounts Committee. I think there was a very full discussion about that there, and I think it's not appropriate or helpful for us to repeat that here in this room. And I think myself, there's a big difference between the authority in 2017 under a different administration, literally breaking the rules, and that not being known or reported to members, and what we're doing today, which is about the exemptions that are being freely and openly reported to members in the context of our committee meeting. I see a big difference in that, and I will bring you back, but I'll finish and I'll also ask Will to speak. And I'm also worried about the message that we give both to our officers and to our partners who deliver services. And my worry is this, that in COVID, we've been asking people to jump through hoops to carry on providing services and support to people in very difficult times. And I regard it as entirely pragmatic to say, don't spend hours and hours doing meeting after meeting and paperwork after paperwork of a commissioning process when you're acting in an emergency to support people in a dire situation. And so my own view, I'm speaking personally, is that I wouldn't want to send a message to either the providers or to our officers that we're so worried about this that be careful about bringing such exemptions again in the future. And I think the fact that both of the members who've spoken about this have said they're going to support the report rather shows that they understand that. And so I just wanted to balance what has been said. I don't disagree with the importance of the rules and upholding them, of value for money. I think a lot of things that have been said I entirely support, but I would want that to be balanced by that other point about how we work pragmatically in this situation, ultimately to the benefit of the service users, because they're getting services that if there's a distraction or diversion through the commissioning process that damages the services, that has a real world impact. And I'm sure both of the councillors that have raised this question would also have sympathy with that point. I will allow Councillor Wilson to come back, but I want Will to add anything. He may disagree with me as well, let's see, but let's see what you say next, please.
Yeah, so in relation to papers 6, 7 and 9, there are sort of 4 key elements and principles that surround these papers, and I just want to outline those just to give a bit of context. And the first one is around the question around, are we getting value for money? And this is a balance between us being able to recommission services in a co-produced way. And that's not just about us being able to do that, but the people that we engage also being able to contribute to that discussion. And that sort of links into the next consideration, which is around the impact of COVID and the impact that that's had on some of our providers and their actual ability and capacity to engage. but also as from an officer point of view, how that prioritises in terms of all of the other priorities that we have as well. And then the third one is around, which is linked, which is sometimes we look for an extension because we feel that we don't know enough about what's coming up and the impact that that's going to have on our services. And this is particularly true for this particular paper, where we know that the way that people behave and the services that they need as a result of some of the consequences of the pandemic makes this service, looking forward, we believe that there needs to be some changes made, but we want to do that in a co-produced way. We don't feel that we are, as we stand today, in a position to be able to articulate what that future looks like. And then the fourth area is, which is a sort of overriding priority for us, particularly at the moment, is around making sure that we maintain stability in our services. So, you know, the last thing, and we're very conscious of this, the last thing that we want to do is start to somehow destabilize through procurement practices some of our providers, particularly at a time when we really need as much stability for the people that's using those services as possible. So there are sort of four main considerations. In terms of the question around have we or have we not followed the procurement regulations, anytime we recommission services, we always engage with our procurement colleagues. The fact that we're bringing these papers here, I think, is indicative of us following process. I'll ask Oliver if he wants to comment, if I may, on the more specific technical questions around procurement quickly, if I may.
Yes, please, Oliver. Do you want to? Can we keep off the older people's day services point, because I'm unconscious Shauna hasn't come back, but on the point of principle that Will's just been talking about and the committee has been debating, Oliver.
Yeah, absolutely. Thank you. So we obviously approach all of our work around the three key principles of procurement, which is equal, fairness, and transparency. The purpose of coming here is making sure that we satisfy our sort of transparency requirement and having everyone be clear about what our intention is. Equal and fairness is we treat everyone as everyone, and being everyone, we mean the providers in the same manner. And our procurement colleagues are absolutely on board with that approach. For this and others, for this paper and others, so more of a general point rather than a specific one here, we have considered options about how to use existing procurement regulations to support us through this. There was a procurement note that was issued in light of COVID, which authorities to extend more contracts, and that's something that we've sought to invoke, but unfortunately we don't satisfy all three of the criteria that are required. Principally, the area that we don't satisfy is that the value of the extension cannot exceed 50% of the value of the contract. So we can't satisfy that. So it's something that we couldn't legitimately use. We wouldn't want to try and force something that doesn't naturally fit. The second thing that we will be doing here is publishing a VEET notice. So that's a voluntary ex-ante transparency notice that sits as part of the procurement regulations. It's something that sets out what we're intending to do. We've taken a number of parts of the information that have been set out in the paper today to committee to be really clear about this is our intention. We're not hiding the fact by any means. We're putting it for all to see, and that allows the process to commence, where if people are dissatisfied with the process that the local authority has undertaken, they can undertake a challenge against that and hold us to account in that way. So it offers us some rigour around the process that we're undertaking for each of these parts today.
Thank you. Normally I'd be saying let's move the business on, but I regard this as such an important point of principle. I am going to allow Councillor Bode and Councillor Wilson to come back for 60 seconds each. But just before doing that, I think the material facts that we heard from Oliver there, Tamar, about the 50% of the value and the publication of the transparency notice, or procurement notice, I think was the right term. I think of important material facts that show that we are trying to bend over backwards to be as compliant as possible. So I would be grateful if they can go in the minutes. I think I saw Councillor Wilson first, so Councillor Wilson, then Councillor Bowden, but a 60-second
Thank you, Chair.
time
And that exactly is the reason why I'm happy to support this extension, because of value for money in COVID and the other reasons. But I just want to go back to something you said about the BDO review of the procurement in the previous administration. The big contract that they looked at was the gritting contract, and the approval for the contractor went to a meeting of spokes, which included Lib Dems, Labour and Conservatives. So all members missed this opportunity to get the procurement right. It wasn't officers, it was a combination of officers and members. And that's what we've got to remember for the future. Thank you.
As chair of the committee now, it's admirable that you put your chairing role so prominently above any party interest. So I congratulate you for that, and that's heard by all members. Councillor Bowden.
Thank you, Chair. I did raise this point for the good of the council, and I wasn't trying to make a party political point, and I don't think this needs to be party politicised, and I fully agree, therefore, with the comments that Councillor Wilson just made. But I must express a concern. Sometimes out of necessity, we need, and we're now in a situation in this case where clearly we do need to have an exemption from the procurement rules. There's just no choice in the situation. Whether we should be in this situation or not is another matter, but there isn't a choice about it. What I'm concerned about is that what has to happen as a result of necessity morphs into something which happens out of convenience. And one of the things which worried me was the comment that you made about needing to stay on good terms with our existing providers. Yes, we are partners with our providers, and it's important that that partnership working takes place, but it mustn't become too cozy. And we must be extremely careful to avoid the partnership working that we've got and the good relationship that we've got with existing contractors becoming one which is so cozy that we end up not ending up getting value for money for our future services. Thank you.
I agree with that. I simply balanced it by saying that putting bureaucratic procurement procedures on providers dealing with an emergency also has a down effect, and we've got to balance both. And I didn't want our officers and the providers that are listening to this to not understand that that is also of concern to this committee and to our administration. A good debate, an important one. There were some points about older people in there somewhere, and Shauna, I don't know if you wanted to come back at all on those points from the debate.
Absolutely. I'll cover off Councillor Vanderland's question as well first, as I think there was quite a full debate around the other three areas. In terms of the key bits of learning we've had from day opportunities during COVID, the provider market has really stepped up and developed a really flexible approach to support people that receive their service through a building-based approach that can no longer happen. So the real learning we've got is actually sometimes virtual works, and we've had feedback from certain area or certain service users and areas of services that say they actually really appreciated the virtual working, and there was a level of anxiety that came in certain environments from leaving their property or having to do that in a timed basis, and the virtual working offered them that level of flexibility and engagement with services that they never had before. So that is something we're definitely taking into learning. The need to ensure that people have access to wider assets within the community, so it isn't focus isn't just on our day services that we formally commission, that actually there's huge amounts of resources and assets within our local communities that could act in any as a day service for individuals, and then leading on to that is the need, which is why the kind of premise of the report is the need to co-produce our solution with people. Day activities and day services are so dependent on the views and the aspirations and the interests of our local population, and those with support needs that they need to, it almost needs to be built around them, and be able to flex around them as they change in those aspirations, interests, and activity, and need or want to engage in activities, whether that's virtual or in a building. So I'd say they're the three areas that we've really taken from the review to date, but there's a lot more work to do with users.
Thank you. That's been a very rich debate and thrown up a lot. Thank you, Shauna. Thank you to Oliver and to all the officers that took part. The recommendations are to approve the grant extensions for older people physical disability day services as shown in Appendix 2 for 24 months, the total value being £1.3 million, and to note the approach for the transformation of day services for older people and for learning difficulties. As there's been controversy, I think it's going to be strongly supported, but I don't want to do anything other than be totally fair and open about these things. I will ask for a vote. Those in favour of those recommendations, please show. And indeed it is unanimous, but the points that have been made in the debate have been heard and will be taken seriously. We now move to item 7, accommodation-based support living services for people with moderate to severe mental health needs in Cambridgeshire. The exemption request is on pages 81 to 90 of the agenda pack, and Guy Fairburn, Commissioner, is going to present the report again online. So am I hearing a point of order of some kind now?
Chairman, with your indulgence,
yes,
please. Thank you, Chairman. Mr. Fairburn and I used to be work colleagues, and even though he's a handsome devil, I will take no prisoners when I'm asking questions of him. We have socialized many times in the past, and I would like to say that we are close friends, if not acquaintances. So just for you to be aware, I won't be making this declaration in every meeting, but just for everybody to be aware now.
Thank you for your commitment to transparency there, and I'm sure he thinks you're a handsome devil as well.
I'm sure he does, Chairman. Thank you.
But I'm not going to take a vote on that in this morning's committee because we're doing so well, and it could obviously be a divisive question, couldn't it? Let's go back seriously to item 7, to the report that's on our agenda paper, and to Guy.
Hello, hopefully you can all hear me. So this is an exemption request for the accommodation-based supported living service for people with moderate to severe mental health needs in Cambridgeshire. It's recommended that the service is exempted for a period of 15 months from the 1st of April 2022 through to the 30th of June 2023, and that has a total value of £1,005,449.65. This will ensure that people will continue to be able to access supported accommodation, learn new skills to become more independent and manage their complex mental health needs, whilst the service continues to be reviewed. The impact of the health pandemic on the service is understood in more detail, and that the outcomes of the pilots, which are detailed in the report, are known, and the service is therefore retendered for. The report has detailed the service, which supports up to 119 individuals, and the main issues identified within the current service, and the pilots that are now underway are being evaluated, which I hope has given the committee a good overview, and that the case study provided has shown a snapshot of the complexity of the individuals that are supported in this service and the outcomes achieved.
Thank you. Just for the record, both for the officers joining us online and also for the wider public following us online, can I just say that there's been some interruption, not just in that report, but in the previous ones from officers in terms of the quality of the line and us hearing everything. We're hearing over 90% of it. If I felt that we weren't getting the meaning, I would interrupt. But I just want to, again, people listening might feel that that should be referred to. So I'm just openly saying that. But I believe, and I would stop the meeting and would change it in some way if I felt the meaning wasn't coming through. But Guy, just to say that to you as well.
Okay, thank you.
Councillor Bowden is first on this one.
Thank you, Chair. Again, I will be voting in favour of this. We have no choice but to vote in favour of a very important service, and there's no alternative. So I will be voting in favour. But again, look at what's happened as far as the procurement rules are concerned. This contract was back in September 17, and it was meant to be a 3-year contract with the option of having an additional year, and we took that additional option within the contract, which is absolutely fine. Then we sought and obtained an exemption for a further 6 months to carry the contract forward to the 1st of April 2022. Now we're seeking a second exemption, this time for a further 15 months beyond that, taking us to the 30th of June 23. And I think that it is really dangerous. You said that procurement rules are bureaucratic, and you said that in such a way as to make it sound as though they came from the European Union and were something which are really bad things, but they're not. Procurement rules are there to protect us, to protect the taxpayer, and to protect the council. And it should be a matter of concern that we are forced, and we are forced at the moment, but that we are forced to have yet another exemption here, which I will support. And what I would ask is that you grab hold of this issue, Chair, yourself, and get some planning in place so that it's clear when either exemptions or original contracts are going to be coming up for renewal in the next 6 to 12 months, to ensure the planning takes place so that it isn't necessarily the case, except in case of emergency, that we will be seeking exemption after exemption after exemption. Now, I was concerned just to make sure that all the I's had been dotted and T's had been crossed. So I go to the bottom of the report that I've just got it off the website as of now, and I look at the final page. Has the impact on statutory, legal and risk implications been cleared by the Council's monitoring officer? Yes or no? And it says, sent on the 17th of November with 3 chasers, no response. So we haven't had a response from Fiona Macmillan, or hadn't had a response from Fiona Macmillan about whether what the statutory, legal and implications are of this particular report. Now, I hope that's been updated and that what's on the website at the moment is now out of date. But that's what the report actually says. And we're left as members of this committee in a very difficult position, because we're here to monitor things. We're here to make sure that things happen in a proper way. And when we're told that it hasn't even been approved by the monitoring officer as to whether it fulfills statutory, legal and risk implications, it just is worrying. Thank you, Chair.
I won't ask the officers to answer your wider point, but I think it's a matter of fact. Has that response from the Chief Monitoring Officer now been received? Okay, just not on the wider point, so we'll have the whole debate, but I don't want something out there that is either correct or incorrect. Let's just correct that straight away. Has the response from the monitoring officer now been received?
Is it clear that you're asking him?
I'm looking at Will, I'm looking at Guy, I'm looking at Tamar. I don't know who would have that knowledge.
To my knowledge, as at now, I haven't received a response.
And Tamar, I'll just ask you that with the microphone on, if that's possible.
When the report was published, Guy hadn't received a response, hence that's why we published it. That it does happen sometimes, and if Guy still hasn't received a response, then we need to get a response from her.
And it would be Guy that should know.
Yes, yes.
And just to confirm, Guy, you're not aware of having received that, yeah?
No.
Okay, there are other points in that we'll deal with by the end of the debate, but I just wanted to get that fact cleared up. I have got next Councillor Daunton, please.
Yes, thank you. Oh, this is really just a comment on 2.1. I know that South Cambs, for example, is part of a county-wide protocol to manage discharges, and there'll be a meeting about that next week. So that was really just a comment to add some detail.
And for his first substantive contributions is joining us, Councillor Howell.
Thank you, Chairman. Chairman, I noticed we're going for a 15-month extension, but with regards to until that particular point, we're actually asking for 19 months from today. So I'm asking, why are we having 15-month extension? Why not 12? Why that time in particular?
Anybody else? Yes, Councillor Slatter.
Okay, thank you, Chair. I share the report's concern about voids. I used to be a trustee of an almshouse charity, and sometimes you can't avoid them, we know that, and sometimes there are delays and you think it's going to be okay and it isn't okay for a bit longer. This report does not give addresses of the people we are contracting with. These are obviously known to officers and would probably be of interest or maybe already known to councillors. They may well be aware of particular properties or groups of properties where there are problems. I remember that being the case with almshouse neighbours. I would just ask that you don't use the full extension of the exemption to let that go on. If there are other ways of using those properties that will also benefit our residents, even if they don't fall into this category, I would be interested to know just how much enterprise you feel free to use. If, for example, this could be backup accommodation for other people who suddenly need a roof over their head. If it's found to be unsatisfactory in its present use, and yet it could come in for some others of our disadvantaged residents or new residents, then I would be interested to know, perhaps not in this meeting, this is a bit of an ambush, but perhaps in correspondence. Thank you.
Okay, my own contribution for we come back to Guy. One is, I won't comment on the detail, but the accommodation provider has been subject to a case involving a serious case review that I've been party to looking at in the Safeguarding Board. And I won't comment on any of the detail of that, but I do think it is a fair question to put to Guy. Are the officers fully aware of that case, have assessed it and assessed that the provider is fully compliant and that the contract is a fair and good contract to reflect the needs arising from the lessons of that case? My comments to Councillor Bowden, I'm very proud to have been one of the members of the European Parliament who put personally amendments to the procurement directives to introduce more social environmental criteria, more flexibility, more ability for local purchasing, and to make that directive not as bureaucratic as some might perceive it to be. And I hope this authority will exploit those flexibilities in the directive, which are also an important part of what that directive intends to achieve. I think the point you make about planning is very fair. And can I just reassure you by saying we're already in discussion between the Vice Chair, myself and our officers about planning ahead so that we don't, we might have to come back with exemptions, of course, but that will have been considered well in advance in discussions between members and officers. It's a very fair point to put to us. I fully accept it, and I just reassure him that is taking place. Finally, I do regard the point about the monitoring officer's reply is extremely important, and having discussed it on the front desk here with Charlotte and with Tamar, what I will recommend as chair is that when we take the recommendations, we'll be doing so subject to the receipt of the comments of the monitoring officer. We will try to use the time between now and the end of the meeting to make sure that's done. It possibly has been done and we just need to get it. And then I'll announce it, I hope, by the end of the meeting. Because I think that's a very fair and important point that's been raised by Councillor Bowden on that point. Guy, on the points that you've heard.
Hi, yeah. So just looking down, noting Councillor Howell's comment regarding the 15-month extension, which is effectively, as he's right, is 19 months. That's been, we've asked for that period of extension because of the amount of work that needs to take place with regards to this contract and the reprocurement. We want to make sure it's a robust reprocurement, that it takes into account and we fully understand the impact of the pandemic. We have some information on that, but we don't believe we have the full picture. And we want to make sure that the future procurement is robust and delivers value for money and is correct going forwards, because we have seen some changes and there's been significant impact within this particular service with regards to housing, the moratorium that there was in terms of people moving in, people moving out, etc. So there has been disruption to the service, and that's in the process of working its way through at the moment. So we want to fully understand that. So we have worked backwards effectively from a planning perspective, from a procurement perspective, and that's why we're asking for 15 months. So I hope that's answered that. Voids, absolutely. It's referenced under with regards to the void management project, and we are very closely looking at all the properties, the type of properties that form part of this service, making sure that they are fit for purpose and making sure that they're the right type of property going forward, and that we are reviewing the voids, and we will be proactively looking at where there is perhaps, whether it's overcapacity or the wrong type of property, and removing those from this service, and making sure that there is, and that would obviously free those properties up for use, because the last thing we want to have is a significant number of void, empty properties, which could be used elsewhere. Noting, just as a brief comment with regards to this serious case review you referred to, we are absolutely aware of that, and there has been and there is ongoing contract monitoring which takes place with regards, as it does across the piece anyway, but from with our contracts team, to make sure that obviously the provider is fully compliant and etc. So I think that's probably the comment that I'd make there. So I think that's answered all of them.
I think it is too. I've now put the recommendations to the meeting, which is to the accommodation-based support living service for people with moderate to severe mental health needs in Cambridgeshire is exempted for a period of 15 months from the 1st of April 2022 to the 30th of June 2023 at a total value of 1.0 million pounds. I haven't actually again heard any dissension on this, so I will take Councillor Bowden.
Sorry, Chair, you did say that that would be subject to the receipt of the information from the monitoring officer, didn't you?
Yep, just to double confirm that, and I will report by the end of the meeting if that's been received or not. If it's not been received, that will then give us a chance to further reflect on the decision. Is that the right way of doing it, Tamar? Yes, it is. I believe, is there anyone who wants to oppose or abstain on the recommendations? No, they are agreed by acclamation, then thank you very much, but subject to the point that's just been announced. We are behind, but I regard the points raised as important and serious, and so I wasn't willing to close down the debate, but if people can just be cognizant of that, because ultimately I will lose items off the agenda if we get too late. Right, the next item on the agenda is item 8, adult social care transport tendering. Gudef Singh, who we regularly see at this committee, is rejoining us. It's on page 91 to 98 of the agenda pack. Gudef is head of commissioning for commercial, and he will present this report via Zoom. Just to give forward notice that we've got proposed amendments, a proposed amendment rather, from Councillor Bowden, and I will take that immediately following the officer presentation. Gudef, please.
Thank you, Chair, and good morning all. This report is about assuring the continuity of transport services for adults with disability and older people, which in itself allows those people to continue living independently and maintain their friendship groups and community engagement. I asked members to note paragraph 1, section 1 describes the journey that we've taken to arrive at this point, which relates to a previous committee report earlier this year. Paragraph 2.1 describes the 3 key factors that affect the recommendations in this report, notably those related to current service improvements, day service improvements, which was discussed in an earlier item, and future-proofing the contracts so we could be working towards our climate change requirements as well. Consequently, in paragraph 2.2, I'm recommending a contracting mix which allows some certainty for providers, which in turn helps us with prices, whilst incorporating flexibility to accommodate those factors I've just mentioned. I mentioned that that members should be assured that we should be calling off from CCZ's own transport agreement, and that we would like to start the work early in the new year with view to a contract or set of contracts to be in place by the middle of May. Consequently, I ask committee to approve the procurement approach the targeted option set out in paragraph 2.2, and finally the delegation of the award decision to the Executive Director of Peoples and Communities. Thank you, Chair.
Thank you very much. Let's move first to the amendment, which is to delete recommendation C and replace with the following. I'll read it out for people who are watching us online. In the light of the recently published Cambridgeshire County Council External Auditors Value for Money Opinion 2017-18 in respect of the County Council's procurement process weaknesses, and in light of the discussion and resolutions relating to this issue at the meeting of the Council's Audit and Accounts Committee on the 25th of November 2021, to bring a report on the adult social care transport tendering process back to the earliest available meeting of the Adults and Health Committee for determination of the award of the new contract. Am I reading out the wrong amendment? I've read it out now. I hear that for other occasions. Apologies. I'm sure Councillor Bowden doesn't object to me reading it out, but I'll observe that in the future. I wasn't aware of that part of the protocol. So that's the amendment Councillor Bowden has put down. Before I invite him to speak, is there a seconder for his amendment, please? Thank you very much. And that is Councillor Corney. So we now ask Councillor Bowden to introduce his amendment, please.
Thank you, Chair. And I do regard it as being quite bureaucratic that you have read it out, not me. I'm quite happy for you to read it out. There's no problem whatsoever. I'll make it quite clear whether this amendment is passed or not. I will be supporting the resolution on this particular agenda item, because clearly it's necessary, and also support the option which has been given. And I've never had any reason to doubt the good quality of the work which is done by Mr. Singh, I have to say, on matters to do with procurement. And we've had a few discussions over the years on different procurement matters in different areas. So I'm perfectly happy with that. What surprised me, however, especially given again what happened at Audited Accounts late last month, what surprised me was that this was not even going to be taken back to the chair and vice chair of this committee for it to be looked at before the determination of this particular contract. And I have to say, if it had said that in the report, I probably wouldn't be putting an amendment forward at all. But given the very high public profile of this particular service, and it can be a service which is quite contentious in terms of its procurement and who does get to do the work and who doesn't get to do the work. Given how high profile it is, and given the comments which had been made from BDO, I thought it was appropriate to put an amendment here to say that in this case, we would like the report to come back to us. And when this happens, when it does come back to us, for procurement such as this, it is always on blue paper, it's always confidential, and it's always anonymized as well, so that it allows us to ensure that a decision, when made, is made appropriately. And if I may just give you an example of how things could go wrong. I must admit, I've been concerned about procurement matters almost as long as the chair has, and I'm very interested in the subject, but it can go badly wrong. And I had a case in the Health Committee when I was Vice Chair of the Health Committee, where there was a contract which had gone out to procurement and it had been scored, and we were being given the scores. And I realised that whilst it had been done extremely professionally by LGSS, which I was chair of at the time, which was providing the procurement services, the officers didn't fully appreciate all the technicalities of the way in which a procurement process works. And we had such differential sensitivity in the scoring systems that a contract which was meant to be being assessed 60% on quality and 40% on price, in fact was being assessed 97% on quality and only 3% on price. That's just because the system wasn't operated in the proper way. Now, it didn't make any difference in that case, because the bidder who came top on quality also came top on price. So there was no problem at all. The right contractor was chosen. But it does go to show how things can go wrong. And it's important that we do have sight of these contracts, these procurement contracts, especially where they are sensitive and fairly public facing, as this one is. Now, as I say, I would have been quite happy for that to have been done by the chair and vice chair, but given that it was suggested that it all be done just by officers, and given the criticism of us from BDO, I thought it was appropriate to bring this amendment forward and to suggest that in this case, this should come back to us at our next meeting or the meeting following, whenever it's appropriate, whenever the timing is right, so that we can ensure for ourselves that the process has been followed properly and that we don't have any questions about the way the process has been carried out. Thank you, Chair.
Just a seconder want to add to that?
Yeah, thank you, Mr. Chairman. I'm not going to say very little, really, but I think I agree. It's a common sense approach. I think us as a committee, we're in charge of today, tomorrow, and next week. not 2017, 2004, whenever. So I think just, it's a common sense approach to move forward and do things correctly. Thank you.
Thank you very much. When I see amendments, I always think, can we support them? Because I think on a cross-party basis, we should try and support each other wherever possible. I know they're well motivated. I think the motivation to be vigilant about us upholding the procurement rules to secure value for money, not to be too cosy with providers. I think these are all very valid motivations behind this. I am going to recommend to the joint administration members that we don't support this though, because my understanding of the impact of this amendment is that it may be perceived as delaying the decision rather than simply reporting it. But that wouldn't stop myself and the vice chair discussing with officers when it is appropriate for them to tell us and when it's jointly appropriate for us to tell the committee. I think it's a very fair question that I wouldn't want to tie their hands on this particular contract, but I do undertake to have that conversation with the officers together with the vice chair, because for me, the reporting openly to the committee is a fundamental principle that is one of the protections against things going wrong, and therefore I do share the motivation of the proposer of the amendment in that sense. But I don't want to agree a policy today that is perceived as potentially introducing delay. I don't think that's the proposer's intention, but it's for that reason that I will be asking the joint administration members not to support this amendment. And I hope that's been said in a good spirit. My understanding of the procedure is that I take any other members just on the amendment, we have a vote, and then we go to the general debate. Is there any other member who wants to speak just on the amendment? Councillor Wilson.
Well, I'd just like to reinforce what you've said. If you and the vice chair are content to discuss with officers at appropriate times during the procedure, then I think that is fine. The head of procurement has said there is no significant implications within this category. So Henry Swan is clearly content with the programme which is planned. And as long as we are confident that you are involved at the appropriate stages and the results are reported back to this committee, I would be content with that. Thank you.
I'm happy to put this to the vote without further officer comment, but I'm just going to look at Will and Gurdef. If there's an issue of fact that perhaps we need to hear before we vote, I just want to give you the opportunity to raise it. Don't feel you have to. Yes, Gurdef.
I would just like to point out, please, in paragraph 2.7, if members wanted us to return back, the next meeting is likely to be in around March time. We would be in the evaluation stage, so we won't have completed that stage, and consequently we won't have information available that could be made available to members.
Okay, I'm now just going to put the amendment to the vote. Thank you, Gurdef. Those in favour of the amendment, please show. And those against the amendment, please show. 6, 7, 8. That's lost by 7 votes to 8, but I thank the proposer for bringing it, and I think there will be action in response to what he said, even if that exact wording isn't agreed. We've all heard the introduction from Gurdef. Are there other points that members want to make in terms of the general debate on this? No? In which case, I'm seeing a hand. Yes, Councillor Bowden, please.
Yes, the option which is being put forward is by far the best of those which are available to us, and I'm more than happy to support this.
Thank you for saying that. I think also there might be a printing error in the report when I reread it. What it said under option 3 in the report looks slightly different from what it said in the draft version, but it makes the point that it's a hybrid that both observes the rules and supports value for money. So I thought it didn't distort our decision making if there is an error there. If I've got that wrong, I apologise. So there is one speaker on the general debate. Councillor Wilson again.
Well, I'm just picking up that I also got a bit confused when options 2 and 3 both say retender now, and you have to work through to see its different contract durations which they're talking about. So maybe that could be clarified. The point I wanted to raise is that we were reminded at Audit and Accounts that the police are still investigating two potential providers of community transport. And I wanted to be clear as to whether or not officers are likely to be considering those providers. And if so, I think the committee should be aware of what is proposed. Thank you.
I'll take a point of order.
Point of order is I am a council appointed trustee of, in fact, both of the bodies that Councillor Wilson was just referring to. And being council appointed, I don't think that that creates a conflict, but I think that it's worth my while pointing out that the police investigation isn't into the organisation; it's into an individual who had defrauded the organisation. So I just wanted to make that clear. I think it's really important, that distinction.
I think that shows we can have a debate in public that doesn't prejudice anything, but enables us to reflect our experiences. I think the question put by Councillor Wilson merits answer. Good, F.
Certainly, thank you. So any provider that we would consider would have gone through a quality assurance process to be awarded a place on our framework agreement, so our formal agreements. If they are on those agreements, then they would be considered for this particular tender. So that's something, if there's a particular organisation or an issue that needs to be checked, then I could revert back to the framework agreement to assure ourselves that those issues have been taken into account.
I'm getting a nod from Councillor Wilson. I hope, again, the minute of the meeting can just reflect the question Councillor Wilson raised, because it does seem to me pertinent that if we know there's an ongoing police investigation, we certainly shouldn't presume anything about it in advance, but it only seems sensible to be aware of that. And I think it's a very fair question that's been put to us. So I hope that, again, will be minuted. I've not heard anybody speak against, so I'm looking around the room. Am I seeing another hand? Councillor Slatter, but this is the final contributor on the debate.
Yes, a very quick one. In 213, there's reference to electric vehicles. It doesn't specify that the providers might well be helped or advised how to get charging points in their business. That obviously is something we want as many people as possible to have available, and especially as some of these may well be available to the community as well. So without wanting to rewrite Mr. Singh's report, we could just, we need to notice all these opportunities to reduce pollution. Thank you.
Good. Do you want to respond to that quickly, please?
Very quickly, yes. So the contract form that we've got has the provision to switch across to electric in due course. Providers voiced views on the practicalities at this point in time, hence we've left that option open in the life of the contract.
I think the point Councillor Slatter is making is that in supporting and advising providers to move to electric vehicles, that includes charging points as well as vehicles. I think that's her point. So I'm sure that will be noted by officers. I am going to take us to the recommendation now, which is, I'm just checking I'm on the right one, page 10. Tamar, I've got that right? Yes. The recommendation is to give approval to the general procurement approach for a contract value of £8.1 million over 4 years. The procuring transport provider in line with recommended option as set out in paragraph 2.2, and to delegate the award of the new contract to the Executive Director of People and Communities, which might be different by the time that decision gets made, but who is in this room listening to every point of that debate. I've not heard anyone against, so is it okay if we do that by acclamation? I always look at nods. Yeah, anyone not happy about that? No, so that is agreed by acclamation. We now move to winter pressures. Item 9, additional home care block provision for winter pressures. It's pages 99 to 106 of the agenda pack. And Ruth Miller, Commissioner, is going to present this report via Zoom. There's also an amendment on this report from Councillor Bowden, and I'll do exactly the same on the next debate, invite him to propose that first before we have the general and deal with that before we have the general debate. So, Ruth, magically you're there in front of us. Good morning.
Good
Good morning. So the purpose of this paper today is to request to award a 12-month contract to an existing provider who has been able to guarantee the council a total of 85,176 home care hours at a total cost of £1,622,790. Home care is considered any support service that a person might need in their own home. This may include shopping, meal preparation, support taking medication, and meeting their personal care needs. Provision of good quality home care not only enables the council to meet its statutory duties under the Care Act 2014, but it is also key in the prevention agenda in that it enables people to remain living independently with their own home for longer. This block provision of home care will allow for people to be supported to return home and hospital, and those with increasing care needs within the community as a result of immediately available home care capacity to support winter pressures. We are already seeing a rise in hospitalisations and people being discharged with the need for care at home. We are experiencing increasing pressures in the home care market, as outlined in paragraphs 2.1 to 2.3, and this block provision of home care hours will enable us to mitigate the risk of not being able to meet the needs of people who require care in their own home. This is an integrated approach funded by Health for the initial 6 months and will then be monitored for the following 6 months if the demand is there. As a block provision of guaranteed home care hours, this contract will form part of a wider system response to winter pressures and ensure those who are discharged from hospital with care needs are able to go home without delay.
Thank you very much indeed. Councillor Bowden's amendment, and having been advised, I ask him to read it out first, please.
Thank you very much indeed, Chair. The amendment is to add at the end of our recommendations, after the figure of £1,622,780, to add subject, given the potential non-compliance with the Public Contracts Regulations 2015 as detailed in paragraph 4.2, to no relevant challenge having been received within 10 days of publication of a voluntary ex-ante transparency notice detailing this award on the Find a Tender Service website.
I ask you to speak to that. Can I see if there's a seconder, please? Councillor Wilson is seconding. Councillor Bowden to present the amendment, please.
Thank you. I read this again with concern. It's another extension, but again, I understand the rationale behind it. I understand the pressures. So clearly there is a need, and regardless of whether this amendment is passed or not, I will be voting for this agenda item. But two things concern me. The first is, and this was merely wording in terms of the title, but if you are putting forward an extension which breaks our procurement rules, and we need to have an exemption to our procurement rules, if you're going to do that for winter pressures, then don't put forward a 12-month period, even if it's only a maximum 12-month period. If it's for winter pressures, it shouldn't be for 12 months. So that was the first thing which just struck me, that if I were looking at this and I were a competitor within that particular industry, I'd think, well, if it was for winter pressures, why on earth is it potentially for 12 months? But what really got me was when I got to paragraph 4.2 in this report, where it says that the council could publish a voluntary ex-ante transparency notice. Given that we are potentially in breach of the procurement rules, the national procurement rules, quite apart from being in breach of our own procurement regulations, given that that's described in the report as being a significant possibility, surely it's essential that we publish a voluntary ex-ante transparency notice. Surely it's essential that we do so. I should just call them VEACH, shouldn't I? It's essential we do so to protect ourselves as far as we can in the circumstances. It's not complete protection, as we know, but it nevertheless provides some degree of protection. And Chair, you'll know this better than anyone in the room. It provides some degree of protection that someone might come back to us in 6 months' time and take some sort of action against us. And it just seemed to me to be astonishing that the word could was used there rather than must, which is the reason for this amendment. Thank you, Chair.
And thank you for not using the acronym VEAT, because for all the public watching, they wouldn't have an idea that of what we were talking about. So I'm grateful that you didn't do that and we explained what we meant by it. I thought that was very helpful. Does the seconder wish to speak, please?
Thank you, Chair. I just want to reinforce what Councillor Bowden said. A 10-day delay is going to be neither here nor there. I'm sure officers can work around that. So I think it's a eminently sensible amendment. Thank you.
The provision for this is in the report. So the consequence of passing the amendment would be to support something that I think there is cross-party agreement with. So I'm certainly going to be recommending that we all vote for this amendment. Did Councillor Ambrose Smith want to comment? Could you use Councillor Bowden's or Councillor Will's microphone? Just bear in mind people are listening online, and if we don't use microphones, they won't hear.
Understand. Regarding the monitoring officer again, hasn't agreed the statutory, legal and risk assessment, risk implications of this particular item.
Okay, so it's a very fair point. So we'll include that in what we dealt with last time and try and make sure we get that by the end of the meeting and make any vote subject to that. It's a very fair point that's been raised there. I'm assuming messages are being sent as we speak. Is someone going to nod at me? Yes, I'm being nodded at, so that's good. But let's go back to the specific amendment. As I say, we've not had any speakers against, and I think as a recommendation we support it. Can those in favour please show? That is unanimous. That is unanimous. Thank you very much. Now to the general debate on this. Which members wish to contribute? Councillor Van der Ven. Can Nick come and help Susan, please, into the microphone? She'll use mine for this next contribution.
Thanks. I figured it was just a good moment in time to highlight again the really important work that's now forming around Care Together, and the questions earlier on about community catalysts and microenterprises, and one of our officers earlier mentioned the rich array of assets in the community, meaning communities have so much potential to be contributing to this whole area. And right now we urgently need sort of the old-fashioned existing way of provision, but we are, it's such a good moment to really consider the potential of what we hope will come on board and all the work that's taken place in East Cambs to bring that to a good point now. Thanks.
Any other members on the substantive report? Councillor Slatter.
A quick, perhaps newbie question. In 2.5, we work in partnership with the Clinical Commissioning Group, obviously to be metamorphosed, and health colleagues. Does that involve any match funding or anything like that? Because it's really important to our hospital colleagues to make sure that people go home and benefit from all the work that they've done, rather than acquire any more hospital-acquired infections. So it's just wanting to make sure that we do make it, if it is a matter of paying for extra hours, somebody's got to pay for it, and it is a bit unpredictable, but it makes a big difference to hospital planning, as well as we know from those of us who are on various hospital boards. Thank you.
Other speakers, just a couple of points from myself. I regard this as actually one of the most important items on the agenda today, because we should link it to what Jyoti was saying at the start of the meeting about COVID, what's likely to happen about COVID, together with flu and other pressures on the health service, which is going to lead to a period of massive pressure on our health service, probably peaking in January. That's what our Director of Public Health is telling us, and our health partners are saying to us. And this decision is extremely important to them in terms that we can ramp up and step up our bit of the jigsaw in terms of providing the social care necessary to deal with that surge in demand on the health service. Its extension beyond March, the point made in the debate, is a really interesting and important point, because it reflects, certainly from what I know in discussion with our officers, would be concerned for the health service that this will the extra demand in terms of social care will continue beyond the time when the government has given extra money to deal with winter pressures, which then has an immediate impact upon our budget. I'm quite happy myself to support the recommendation, which means that we would put that into our budget if we can, though we'll have to fight for it. We're not yet there, as we'll hear later in the meeting. But we should recognise that we're right at the sharp end here of trying to deal with that surge in winter pressure that exists on our health service. And this isn't just about contracting and procurement, which it is, and important rules around that. It's also about us being able to step up and meet these dire and urgent pressures that there are on our health service, and the people who are the patients and our residents who need to be in receipt of this extra home care service. So I thank the officers for, I know, some quite intense work on this area. Are there any replies from Ruth? Oh yes, you come back onto our screen. You disappeared for a moment, but you're now back. Are there any replies from Ruth to any of the points that you've heard in the debate, please?
Yeah, absolutely. So I'll just go through. So Councillor Howitt raised the issue with the approval from the legal officer, and I have had that approval. It was prior to the paper going out, so all approvals have been sought and have been recorded. So just wanted to add that. In terms of Councillor Slatter's point of in 2.5 of the joint working in the match funding, so the first 6 months will be funded by health, and then the following 6 months will be funded by social care, and there are other contracts to do with this that are jointly funded as well. So that is something that we work towards. In terms of Councillor Bowden's point, for 12 months not being winter, so the consideration is that 6 months would cover those winter pressures and we were putting the service in for that. One of the issues is when awarding contracts to providers, they don't always go for 6-month contracts, particularly with this service, as the providers have to lease cars in order to provide it. So the provision is actually for carers within cars, and the cars are leased 365 days a year, and that's one of the reasons that we give it as a 12 months, as well as the summer holidays. We saw this year the summer holidays were really quite difficult in terms of the care market. A significant amount of carers are on 0-hour contracts, and we find from feedback from providers that that carers often will essentially hand their notice in at the beginning of the summer holidays, not work through the summer holidays, and then go back to being a care worker in September, and this puts significant pressures on the care market and sourcing care for people at home. So that's why we'd like to have that further 6 months, and it will all be under review, and we meet regularly to check the demand and the supply to ensure that this block provision is needed. So I hope that answers the question, and yeah, I hope that answers the question.
Thanks. I'm well behind time. Is it a point of order, Councillor Howell? It isn't. I have closed the debate. I think if I'm not a bit tough on now, then we're going to lose whole items, and we may do anyway. So I apologise to him, but I'm going to move on. Will's just got something to add in terms of the officer report before we vote.
Yeah, the other thing I'd add to this is this service, this type of service, these types of arrangements are being commissioned, but whilst we're commissioning those to meet demands that are facing us now, when we come on to the business planning update, you'll see within there that we are actively trying to find ways of commissioning to meet need differently. So to give an example, the Care Together work, we hope, will be a much better model than the model that we are asking, that we've talked about in terms of the block cars. So for us, it's not a long-term sustainable approach to meeting need.
Okay, so thank you for that, Will. And I just make the point in the report, it says there's a break clause. So if we can't fund it for some reason, that break clause is there. And I make the point to members, it's our job to try and get this in the budget if we support it. I think that's an important also response to what we've heard. Just to say, it was Councillor Ambrose-Smith who raised the issue about the monitoring officer, not myself, but as we've heard, the monitoring officer's response has been received, and so we can take that worry off the table, but it was completely proper for him to raise it. The recommendation is that we award a 12-month contract to existing provider to guarantee the council a total of 85,176 home care hours at a total cost of £1.6 million. Sorry, can I just look around? Is anyone wanting to oppose or abstain on that? No, can I get this agreed by acclamation? Sorry, Councillor Bowden.
Just for completeness case, that is subject to the amendment as well, of course.
It is indeed. The amendment's been passed, so that will be part of the substantive. I saw lots of nods. Again, I'm just any shakes of heads I'm looking for. There are none, so that is agreed by acclamation. And I regard that 85,000 home care hours, 1.6 million to deal with the winter surge. I think that's a really significant decision by our committee today. I'm going to try and get through the next item and then have a very short break for anyone who needs a comfort break. And can I just give advance notice that in terms of the key performance indicators report, I don't know if that's the exact name of it, I'm going to suggest that we take that as read because it's only previewing a later report that's going to come to us next year, just so that the officer waiting doesn't wait patiently and then we don't get time to it. And I'm probably going to say that the future agenda plan and the training plan should just be noted without discussion, but if members want to speak to officers about any of those, we can. So I'm just giving that advance notice. Councillor Bowden.
Chair, given that you're giving that advance notice, may I just make a request? I think it's ever so sensible that the future agenda plan, on every agenda, there should be a report on the situation so far as COVID-19 is concerned. It seems remiss that we don't have that as a matter of course.
Okay, that's been heard and I'm sure it will be minuted. Let's try and get through the next item though, because I'm aware some people may need a comfort break. It's Shauna again. It's the urgent decision item outlined at the start of the meeting and emailed to all members yesterday afternoon. Allocation of infection control, rapid testing, vaccination and workforce recruitment and retention funding in response to the COVID-19 pandemic. Shauna Torrance again via Zoom. Shauna.
Thank you, Chair. So this is one of a series of grants that the government have issued throughout COVID, and the recommendation is to approve the allocation of the discretionary elements of the infection control, the rapid testing, the vaccination and the recruitment and retention grant. These have been issued on a one-off basis by central government to cover spend between the 1st of October 2021 and the 31st of March 2022. The funding allocated has been outlined in section 1.2 and it aims to reduce the rate of COVID transmission within and in between care settings, ensure rapid testing is undertaken on staff and visitors to prevent spread of infection, and to support the sector with recruitment and retention challenges throughout this period. The recommendations outlined in section 2.1 have been made in consultation with local care associations, public health and internal teams. The terms of the grant stipulate that they need to be allocated within 20 working days of receipt, and an urgent decision has been requested with this timescale in mind. Thank you.
Thank you very much. There's not much discretion in the rules about dispersing this grant, but following internal debate, and as the committee was on, we thought it was important to bring it to committee, and thank you for the representations that have been made about that. Clearly getting the money out there quickly is really important in this instance. Does anyone feel the need to speak on this? No, so the committee is asked to approve the recommended allocation of the discretionary elements of the infection control, rapid testing, vaccination and recruitment and retention grants, which have been issued by central government on a one-off basis to cover spend between October 2021 and March 2022, where this falls in line with the grant conditions sent. Is there anyone who wishes to vote against or to abstain on that recommendation? No, that's then agreed by acclamation, and thank you very much. I'm going to be tough, but 5 minutes break, is that going to be enough? Does anyone need longer? 5 minutes break, so it's 23 minutes past now, 28 minutes past, we resume. Yes. Thank you very much. A couple of announcements. One is we have now heard back from the monitoring officer on the question of the supported accommodation for people with moderate to severe mental health issues, and she has cleared the report. So we can move forward on that without any further delay or anxiety. Secondly, Jyoti's just been feeling a little unwell, and just to avoid any concern about anything, because infection control is one of our key priorities, she's withdrawn from the meeting and will be going home and working from there. And Val Thomas, the Deputy Director of Public Health, is joining us, and she will present the report, the rest of the reports on behalf of Jyoti and the team for the rest of the meeting. And I think one of the members also is feeling a little unwell, may have to withdraw, and that will be very understood when that happens. And no one's infecting anyone else, because they're all being super cautious about it, and well done to them. We now move to item 10, the Finance Monitoring Report, October. This is going to be a joint presentation by Justine Hartley and by Val. It's item 10 in your agenda pack, pages 107 to 172, and Justine, who's Senior Strategic Finance Manager, will start the report.
Thank you, Chair. So this is the report that you normally see at every committee meeting. This is the position as at the end of October. Normally you are asked to review and comment on the report and nothing further, but this time you've got some decisions to make as well. So I'll just quickly run through the sort of 4 areas that to cover.
Could you bring the microphone just slightly closer to your mouth, please?
Yep.
Just so you
Sorry, I can hear it bouncing back. So the headline position for adults and safeguarding at the end of October was a forecast of 4.6 million underspend. And just to say, really, this is a sort of historic thing about the budget, the really devastating impact of COVID on the numbers of people we support. And we didn't rebaseline the budget at the beginning of the year because of the impact of COVID. And that's why we're seeing these underspends now. It's nothing to do with any kind of reduction in service or anything. So 4.7 million under on adults and safeguarding. Public health, also underspending by about 1.5 million. And that is about largely about staffing, very difficult to get public health staff at the moment, as you can imagine, and about contractual services with primary care and the focus of primary care on the vaccination rollout and other issues. So that's the headline position. The first of the decisions that you're being asked to make is in respect to a requested transfer from £2 million from the current year underspend in adults to the adult social care risk reserve. So we have a risk reserve that sits on the balance sheet. It was created last year. And just reflecting back on what I said about the impact of COVID on the service numbers that we're supporting, we are in very uncertain times in terms of the impact of COVID going forward. So we are proposing, as part of the budget paper, which is the next item on the agenda, to reduce the budget permanently for adult social care. And this risk reserve really is to sit there just in case the numbers start to move in a way that we're not expecting. So we know there's a lot of pressures in the health system in terms of people waiting longer for treatment, and that all of those things might impact on our costs. So this is a risk reserve just to cover us off against that, and that gives us the confidence then to give up that budget on an ongoing basis. The next decision you're being asked to make is about public health reserves. I'm just going to set that on the side for a moment and go to recommendation 4. Again, this one is about noting, and this is about waivers from full contract procedure rules. I know you've talked a lot about procurement this morning, but we do have an approved process whereby you can have a waiver and in exceptional circumstances and with appropriate approvals, and the top approvals would come to this committee. None of these ones are of that value, but understandably, because of the pandemic, there have been a lot more waivers in the public health arena than there would normally be, and so it was felt that it would be good to just bring these to this meeting for your attention, and they are all listed there, as I say, all in compliance with the waiver process, and just brought to you for note. So going back to item number 3, this is about public health reserves, and looking at some options for use of those reserves going forwards, which was something that we discussed at the last committee meeting, was requested by members that we bring this back. So the table on page 112 shows that the balance on public health reserves at the moment is 4.6 million. And of that, we've got committed 1.2 million, and we've got uncommitted 3.4. So in the table below, then you've got some proposals that have been pulled together by the public health team, and Val's going to talk about those in just a minute. I just want to say one more thing before I hand over to Val, and that is about where we would expect to be if you approve these, what the balance on public health reserves will be. So alongside this, we're obviously going to also look at the business planning paper, and there is recommendations in there for use of just over £1 million of public health reserves as well. The 2.9 million plus the 1 million would be obviously over the level of uncommitted reserves we've got at the moment, but because we're forecasting a £1.5 million underspend, and that will go into public health reserves at year end, that will mean that all of this can be covered, and we would still expect, even after the approval of all of this, that at the start of 2023 there will be 0.9 million of public health reserves remaining, and we would suggest that there is a balance held there, because A, we haven't heard what the public health grant will be for next year yet, and B, we need to work through the implications of the NHS pay scale rises and what that means for our relationship with contractors and the amount of inflation we have to pay to them. So we need something left back to cover for those things, and that's why we are sort of recommending a list of proposals, but with a balance left at the end. And I'm going to hand over to Val, who's just going to talk you through some of those proposals.
Thank you, Justine. Yes, we looked at this quite carefully. We're very much aware of the reserves, and very much in the context of the impact that COVID has had on our services. So we went through a very thorough process within the team, and we asked for proposals, and these were assessed against inequalities and against the 4 health and wellbeing, but the new priorities of the health and wellbeing strategy. So it's very much the proposals that are described here very much reflect our business as usual work that has been affected by the pandemic. There's some funding in there for some additional staff. I think, as Justine alluded to, that is a problem, and certainly we've lost staff in the course of the pandemic. So we would like to bolster those resources so that we can make best use of any additional funding. I think you'll notice that the biggest spend is to address the impact felt on our weight management services. We have accumulated quite a large waiting list in the course of the pandemic. This is the intensive face-to-face service, which cannot be provided in virtually. Well, it can be to some degree, but for a lot of people, they did not access services. So we have a several hundred waiting list. We have already had support from the CCG, which has given us some additional funding to help deal with it. But this additional funding will, over 2 years, will help us to address that, that rather substantial waiting list. So any questions about the detail of the proposals, I'd be happy to answer.
Right, thank you very much for that report to both Justine and to Val. And as Justine said, we'll also, in the business planning report next, there's an interrelationship between some of the recommendations here and some of the recommendations in that. So hold back if your point is more on the latter than the former, but we all recognise the interrelationship between the two. And in opening debate, I just want to say I find the set of proposals about use of the public health reserve really exciting. And there was concern in the joint administration, but I think from members across the committee in all parties that we really address that. And I think the work that's been done to come up with what I think is an excellent set of proposals is really, really good. And I really thank the officers for that. Let's open up the debate, and Councillor Bowden is first.
Thank you, Chair. I'll speak, if I may, on the public health reserve spend in particular. And you'll recall, Chair, that I was the one who brought this up at either the last meeting or the meeting before, maybe both. My concern that at a time of pandemic, we appeared to be accumulating a larger and larger public health reserve with no plans to spend it. And you told me, wait, and those plans will be revealed. And so far as these go, I support them. I say so far as they go because we are in a very difficult situation. There's no doubt at all about that in terms of public health. And we're not talking about one-off spends here. In many cases, they can't be one-off spends. If you look at the utilisation to support the loneliness and isolation support work, it's over the period 22, 23, 23, 24, and 24, 25. And my fear is that we're still being rather cautious about the utilisation of the reserves. If we were planning to spend all of the monies which have been talked about in 1 year, then I would think that's more ambitious, but it's not necessarily the case. Additionally, and please do, if officers could correct me if I'm wrong on this, and I may well be wrong on this, but it looks to me as though no provision is being made for an underspend on public health in 22-23. Now, you wouldn't normally start a budget process by assuming you're going to have an underspend on what you're doing in a budget process. But with the continuation of COVID pressures and with the knowledge that for the vast majority of the spend that we've got on public health, we're talking about longer term contracts or medium term contracts, I think that it is reasonable to assume that we're going to have an underspend on public health again in 22-23, which will just add back into the reserve, which is only in some cases being slowly depleted. So I just wonder if we are really predicting and utilising the public health reserve as fully as we might do. I'm not suggesting for 1 second spend every penny that's in the reserve all at one go, but I just wonder if we're allowing for the fact that just as it's likely, it's pretty certain that the public health reserve is going to go up again this year, probably it's going to go up again next year as well. And we're going to continue to have a higher level of public health reserve than we can really justify at a time of pandemic.
Thank you. I noticed Jyoti has appeared on our screen. If you wave at me, if you want to speak as well, Jyoti. I do slightly worry that you're definitely not in your own home. That looks like this building, another part of this building, and I don't think you could have got home in that time. So I'm just slightly worried that you might be there, and perhaps shouldn't be in your own interests. So I hope you're okay.
There's nothing around me. I'm just waiting for a lift, and I'll be off.
Okay. So if you disappear, we'll fully understand. And again, we wish you well. Can I take other comments and questions before I come back to officers, please? Councillor Wilson.
Are we noting, or can we raise questions about the savings tracker we talked about noting the KPIs, for instance.
Is that this report, the next one, Justine? Is this report? Yeah, so
Yes.
Councillor Wilson.
So the
please-
bottom
please
of page
raise it.
167, because I'm very happy with all the rest of the report and it's very comprehensive. But there's two things which I wanted to clarify. One, the red savings tracker about client contributions policy change says ongoing difficulties in recruitment have continued to delay the reassessments project, which I can understand. But the savings delivery is fully mitigated in the forecast by increases in client contributions, not directly linked with reassessments. And I'm always a bit concerned that we are picking on clients who may or may not have the ability to properly resist what officers are demanding of them. And then the other question was on the line above about block care provision. This seems to imply that we're subcontracting some of the block purchase provision in care homes, because it says income can be generated to offset the vacancy cost by allowing people who pay for their own care to use these beds. So are we making a profit out of that? And does that imply, if we are, that that's a revenue generation which is beneficial to us, and therefore we're not having to go for spot purchase at the moment? Thank you.
Thank you very much. Justine will obviously answer that substantially, but I'm just checking. I am assured that there are no new charges being proposed in the course of this report, but Justine will answer that in detail. But that is an issue that the Vice Chair and myself have been in regular discussion with the officers on. Anyone else on this report? Councillor Van der Ven.
Thank you. I just wanted to say, with regard to the proposals under public health, how important these are, and recognizing that our public health staff have been completely diverted to the pandemic, and it's a very difficult situation to be in, and yet it's vital that we try and get these programs underway. It's stating the obvious, but just wanted to say it. Thanks.
Some concluding comments from myself. Firstly, on this issue of the underspend and the moving of the money into the reserve, I strongly support this. I've been saying both in internal and external meetings every month since we started the budget planning that there are huge fluctuations in the figures month by month, and our officers are watching carefully that and continuously updating our plans. But we just have to recognise that the impact of COVID means that quite a lot of that is not fully predictable and is rapidly changing. And so at each meeting, we're going to be getting these reports and then potentially having to look at widely different figures than we've seen before. But I do know that the officers are completely on top of this, and they're doing all that they possibly can. So I just report that. And I think the creation of that reserve, that risk reserve, rather than just rebaselining downwards, is an eminently sensible way of catering for risk. So I think that's a really responsible thing for this committee to be doing. So I strongly support it. I think the points will be answered by officers that have been raised about the use of the public health reserve. But my own view, listening to Jyoti and her team, is that they went through the most comprehensive exercise looking at meaningful ways of spending it, not just spending it, but really meaningful ways that they feel that they can deliver on despite all of the pressures, and which reflect the needs, the health needs that there are in the community. And that's one of the reasons I'm so excited by the list that we see. And Jyoti spoke to Councillor Van der Ven and myself about this retention of the 0.9 million that Justine refers to, and really wants to see that retained for the reasons that Justine has said. And I'm comfortable that that is the professional advice that we're given for our own officers. I don't think that does fully answer the point from Councillor Bowden about further possible underspend. So I'm sure the officers will respond to that. Having made those personal remarks, I now hand back to Justine and Val, please.
Thank you, Chair. So on the underspend forecast potentially for 2023 that Councillor Bowden was referring to, I think from a prudence perspective, we know we're forecasting an underspend in this year. As I said, we don't know what the public health grant is next year. Now, you know, one would hope that what we've been told, it will be equivalent in real terms to what we've got this year, but we're not expecting any more than that. So I think really this is about just taking a prudent approach, using what we've got. Almost we're committing based on the current year underspend, and I don't really think that's a particular risk because I'm pretty sure that that will come to fruition. But I'd be slightly reluctant at this stage to commit into next year's forecast, you know, next year's proposed underspend, although by the time we get there, of course, we might do. In terms of spend across the years, and the fact that some of this is more long-term than you might have wished, Val might want to comment, but I think there is, as I've said before, a very real risk, you know, a very real issue around getting the staff in to deliver a lot of these things. And so the public health colleagues are having to be quite innovative in trying to find ways to do some of these things. So, you know, there is just so much demand for public health experts that it's very difficult to get them. Do you want to add anything, Val?
Thank you, Justine. Yes, in terms of next year, I think if we go back to the source of our underspend is very much based on our services in primary care and all the pressures on primary care. And so, you know, we just haven't had the delivery and the activity levels that we would hope for. I think looking at where we are at the moment, that will continue on into next year. But I think what we are doing proactively is to look at other ways we can deliver those services in primary care, so it won't impact on those very pressurised primary care staff. And those are the negotiations that we are in at the moment with to bolster the capacity in primary care through different routes. And there are options out there, and we are discussing that with primary care colleagues at the moment, because that, I think, probably those activity levels will continue to be down next year because of the situation we're in and the whole recovery process as well. So it's a very good opportunity to look at how we can address needs in multiple ways.
Thank you. And of course, we've got our primary care colleagues this afternoon, so I hope the members will ask that question about how we can overcome some of those difficulties to them when they're with us this afternoon. On the officer responses, both Jyoti and Charlotte want to add something. Jyoti?
Thank you. I just want to pay tribute to my team who've actually worked really hard to develop these proposals. It takes time over and above what they've been doing to respond to the pandemic. You know, these haven't just kind of appeared overnight. They've been the product of a lot of hard work. I think we, in terms of the delivery as well, not just our workforce is limited, the workforce for delivering some of these projects is also limited. And I think to put all of the money out there in year one would just lead to the money not being spent because the workforce wouldn't be there to deliver against those proposals. I take on board your point that we may accrue further spends and we may not need the amount that we're keeping back to manage risk, and I will ask my team to develop further proposals as a contingency so that we can continue to spend as money is available to us.
Thank you. And perhaps that point about developing further proposals as a contingency could go in the minutes. That's something that would be very helpful to record. On the charging point, Charlotte wishes to add something.
Yes, just in response to your comments, Councillor Wilson. So, and to be really clear, there's been no change in the contributions policy. This is a policy that was agreed by the previous committee. There has been a delay in implementing the policy for the reasons that are in the report, and contributions do vary year on year, which is unrelated to the changes in the policy, the result of many factors. It's often very hard to predict actually in each year what the final position will be in terms of contributions, but just to confirm, officers would never directly target somebody because they weren't able to sort of make their case. We've got a very clear policy and it's there for a reason and we work within it.
Is it a point of order, Councillor Bowden? I have closed the debate, I'm sorry. I'm trying to give people a decent break. Is it a point of order? I'm going to be completely fair across the party aisle.
Quite right. No, I had raised a comment about subcontracting block beds which I don't think will.
Was it a question that's been unanswered? Is that what
Correct.
you're saying?
Yep.
Yeah. Okay, that's very fair. Who, Justine, could you, no, I'm just looking, Will then. So apologies, unanswered questions, fair enough. Will.
Yeah, so Councillor Wilson answered your question. Where we block purchase residential based beds, one of the ways that we manage the voids, so where we have voids, rather than pay for those voids, providers, there's the ability providers can ask us to release those beds to them, and they fill those beds with self-funders. But in exchange for that, we ask for either a discount or a proportion of income as a result, and we use that to reduce our overall cost of the block, so that we're not paying for the empty bed, and that we're creating income that helps discount the total cost of the block.
Thank you very much. I'll now, it's got to be a point of order.
No, but mine was also a question which wasn't answered.
That's fair then.
Thank
I
you.
apologise. What was the question?
The question
Just
that I
remind us.
asked was, given that the spending of some of the public health reserve which is being spent, which I fully support, that runs over more than 1 year, in some cases 2 or even 3 years, and given that there appears to have been no provision made for underspend in 22-23 on the public health reserve, doesn't that mean effectively that we won't be reducing the public health reserve at all, or at least not as much as we think we're going to? And I think that the
with respect, Councillor Bowden, I listened to the answer from Justine, and I think that was answered. I'm going to put the recommendation to the committee. It's to review and comment, which we've done on the relevant section of the Finance Monitoring Report as of the end of October. It's to endorse for approval by the Strategy and Resources Committee the transfer of £2 million from the current year underspend in the Adults and Safeguarding Directorate to the Adult Social Care Risk Reserve to mitigate against future pressures arising in 2023 and beyond. It's to review the current position on public health reserves and endorse for approval by the Strategy and Resources Committee proposals for the use of uncommitted reserves totaling £2.9 million. And it's to note the approval of waivers from full contract procedure rules that have been granted in the Public Health Directorate during the exceptional circumstances of the COVID pandemic. We have had a debate on this, so I'm going to actually take a vote. Those in favour of those recommendations, please show. And those against, please show. And those abstaining, please show. That's 12 for and 2 abstentions. Thank you very much. 3, I apologise, there's a third one I didn't see. 3 abstentions. We now move to item 11, review of draft revenue business planning proposals for 2022 to 27. They're on pages 173 to 418 of the agenda pack. Democratic Services have highlighted that there was an error when uploading the documents to the website, and that there are 2 copies of Appendix 1A, Introduction to Financial Tables, in the agenda pack. Can I ask Will Patton, along with Justine and Val, to introduce the report? Will first.
Thank you. So we last reviewed business planning proposals in the November committee. As we said then, it's an iterative process, and I'd like to highlight the key changes that have been made since then. The first thing I'd say is that we've incorporated the feedback from the November committee, and that's summarised under section 6.4 and reflected in the business cases where appropriate. We have also incorporated the national living wage increase, so moved from £8.92 to £9.50, and that's had an impact of 3.2 million. We've also now incorporated the health and social care levy on providers, which we estimate to be £1 million. And we've also incorporated investment to move our providers towards paying the real living wage over a phased period, and also investment in public health for the introduction of the health impact assessments. Under paragraph 6.7.2, we set out the one-off investments. They're not yet in the tables, but they are proposed to be funded from reserves, and they include initiatives such as Care Together. And the last point that I'd make is that it is an iterative process. There's still a bit more work to do, a bit more fine-tuning, and we are still working and looking at emerging pressures with our providers, such as the workforce, and also things like the impact of the social care reforms.
Thank you very much. We had a special meeting just on this in October, when we had a very full debate. As Will has said, I hope you've seen where points raised on that day have been built in. This is an update. It's obviously still a staging post towards the final budget. Are there any questions or comments on the new information put forward before us today? Councillor Wilson, you would disappoint me if you hadn't contributed.
I think it's probably because I don't understand it. On page 178 in 4.1 about assumptions and risks, there's a bullet about high needs deficit. If the government changes the approach to funding, the government will have to fund the high needs deficit, resulting in the exhaustion of unallocated reserves, which sounds serious, and I don't know whether I should be concerned or not.
I think it's a CYP point rather than a adults and health point.
Then let's move on.
So let's bring Councillor Goodliffe in, who's been uncharacteristically quiet so far.
Thank
so I've
you.
tempted her to speak.
The high needs deficit refers to the SEND or special educational needs disability deficit. So it's an ongoing large thing, but no, thankfully not for today. Thank you.
It's a huge problem for our authority, and of course we're collegiate, so we're not saying that's just a problem for children and young people, but it is a big challenge. But our children and young people colleagues, I know, are addressing it very, very thoroughly. Yes, Councillor Van der Ven.
Thanks. I know we have thanked our officers earlier in the meeting on several occasions, but the enormity of this piece of work, I think, deserves another special thanks. It feels like going through very high waves all the time and knowing that there are more ahead. And so I really just want to record our thanks for all of your work, and also to bring this to committee in such detail as early as possible to give us the greatest understanding ahead of our February council meeting. Thank you.
And I join that sentiment, absolutely. The recommendations are to note the progress made to date and the next steps required to develop the business plan for 2022-27, to comment on the budget and savings proposals as we've done that are in the remit of this committee as part of the consideration of the council's overall business plan, and to note the updates to fees and charges for 2022-23, but it'll be minuted what Charlotte said in terms of what those are. Please. Is there any controversy about this? Anybody want to abstain or vote against? No, is this agreed? I'm seeing nods. Am I seeing nods? I am. So that's agreed by acclamation. We're nearly there, folks. The key performance indicators, I've already announced that we'll take that report, we'll note that report and take it as read. The recommendations are for further work to do and to come to this committee on that, and so I don't see that being prejudiced. Tom Barton's done a lot of work on that, and so I apologise to him if he's listening or a message could be passed to him, but we're fully supportive of the principle behind that. Similarly, the training plan, and similarly the agenda plan, that I note what Councillor Bowden said in his earlier comments about the COVID issue, which means at 1 o'clock on the dot, all right, give me some credit, at 1 o'clock on the dot we reach the end of the morning part of this meeting. We'll have the next hour as a break, and we move to the health scrutiny section. Please be here promptly at 2 o'clock. And once again, to all the members in the room, this works if we all participate. So I want everyone to be as participative as possible in putting questions to our health partners who are bringing some time and have produced some really good reports for us. But it only works if we do our job as well. So I'm looking forward to people putting in questions on all of the items this afternoon. I really encourage you across all sides of the council to do so. The meeting's adjourned. We resume at 2 o'clock. Thank you very much. Wow. At 1 o'clock. I really wouldn't believe that. Well, one is I think people are tired, but we did give
Good afternoon.
Good afternoon.
Good afternoon. The meeting is currently being live streamed, so you might want to know that before you do anything. And the members are currently on their break, but they should be arriving back at 2 o'clock, which is when the meeting will start. But thank you very much for arriving. If you wanted to rename yourself, you can click on right click on your name and rename yourself in the participants. Thank you.
Excuse me for a second.
Right, I just want to welcome Ashton. Can I just check, Ashton, that you're hearing me?
Yes, I can hear clearly. Thank you.
Brilliant. Okay. If you're just patient for a short while, we're going to hear from Sandy first, but to Corinne, who's just joined us, and to other speakers that are joining us as we speak, you're all welcome. Thank you very much for joining us, and I'll introduce you in turn when we get to the items. But first, Sandy, I'm hoping, Sandy, you can hear me this time, and we ask you to address the meeting. Thank you.
Thank you. Yes, I can hear you. Thank you, Chair. Sorry, I had some interference there. So sorry, I hope you can hear me okay. So thank you for the opportunity to present our intelligence to the committee. We've had an increasing amount of intelligence since the pandemic started regarding people's concerns about getting appointments with the GPs, and it's a range of issues. So I've listed them down in the report. So I'll take the report as read, but some of the things I would like to stress is the inconsistency. So just to say that a lot of people are getting a really good service from their GPs, and they've been able to see their GP, and lots of people have told us how great the services are that they're getting, that they appreciate this, and also that people are really pleased that they can consult their GPs in different ways. So the ways that our communities have embraced new technologies as have our primary care services is really to be highly commended and really promising for the future. But there are people that are still experiencing significant problems, and some of these is explained in the report. And particularly it's the circular nature that people find frustrating, I think, and I think it is just a general indication of the pressure in the system as people are waiting longer for diagnostics and tests and referrals to hospitals, and they're not sure where they are, so they're trying to ring their GP, which kind of like adds up to the numbers of people trying to get to their GP, and it does unfortunately increase the chances of people getting lost. And the same thing with 111, there's a bit of a circular thing going with 111 and A&E and GPs as well. So we completely understand, and we're trying to explain to people that contact us how difficult it is for everybody, and we're really hoping that we're really pleased to see that the CCG and GPs themselves have really been listening to things that we've been saying, and I'm pleased to see the report that you've got in front of you that you'll be hearing about with some of these solutions. I think it is an opportunity to get some really good information out there to communities so that there can be a really good focus on self-help and self-management and people looking after themselves. And we have got a report coming up early next year around waiting to people's experience of waiting for care. So we'll be looking to have more information in the public domain about that in the new year. And we do look forward to some better websites as well. And I know that colleagues in the CCG have got something to say about that. So I hope that's helpful. Happy to take questions.
So this whole item 14 is all obviously on primary care. What I'll do is just take questions, if I may, that are specific to Health Watch to clarify something in the report or something that you've heard there. And then in terms of the major points, let's hear from the Gary and Jessica from Primary Care Networks before we then have the major debate. So just questions of fact based on the report or the presentation that we've just done. Councillor Hay, please.
Thank you, Chair. What I would like to know is when you were doing your research into what is going on at individual surgeries across the county, did you find much difference in the level of services being provided? What I'm thinking of in particular, my local GPs currently are not doing annual asthma checks online. Prior to the pandemic, they did minor surgical procedures. They appear not to be doing those. Is this a case right across the board? Have they been advised not to do these type of things? Or are some surgeries commenced doing these?
So we didn't specifically ask
So
those
just Sandy, if you could just hold on, and I've got at least one other hand. I'll just check in case I have any others. I just again encourage members to, as that question properly did, put questions to Healthwatch, but I'm sure that Gary and Jessica will be noting where the members are interested, and perhaps in their presentations might also pick up on these points to avoid us duplicating. Councillor Howell is next, and then Councillor Wood.
Thank you, Chairman. Chairman, just 2 points really. At the top of page, I'm so sorry, I've lost it now. Yeah, top of page 454. There's some bullet points there. They're not very clear in the way that they have been said on that particular one. I'll just draw attention. For example, it says there. Accessibility, 14 volunteers said no good examples were found. 7 volunteers said they found good examples of accessibility, but that's out of 23. So it's not clear. I think that could be tidied up a bit, them particular bullet points. That's a small point. Chairman, and what I want to say is that I too, I think like many of us here have had people saying about trying to get appointments at GPs. And I think the one thing that's come back to me quite a lot is that the GP seems to be quite happy to do the COVID jabs or the boosters. But when routine blood tests, which are needed by the people for their medication, they're not so keen to do them. And that has been a constant problem with people worrying with regards to routine medication being put to one side. So yes, I just want to back up what has already been said in the report. Thank you, Chairman.
Thank you. As I say, I think to avoid a duplicate debate, one is for us as members, let's try and just restrict our questions to questions of fact on what we've heard from Healthwatch, because I think that's as relevant, what we've just heard there from you, Councillor Howell, for our PCN colleagues as well. I've got Councillor Wood next.
Hello. Like the last question, when I looked at this, I mean, it's section 2.2, 150 people have told Healthwatch Cambridgeshire what their experience. I mean, what I'd like to see is a table, I'm afraid, we're presenting the data. And I wondered, this is a voluntary survey. I assume I'm correct in that. What I'd like to see is whether you're getting a lot of responses from certain areas. I can quite see you don't want to go down to small area or GP practice level, because there'll be sort of issues of disclosure possibly. So that is my first question. And you know, can we see how the survey was done? I'm looking forward to seeing your next report. One of the things I wonder whether people asked was the use of photos and trying to send those into GPs as part of the appointment, virtual appointments. And then I did wonder, I don't know whether this is for the next question, but working with Cambridge Online, because my worry is with all these, with the use of online engagement or appointments, it can be quite difficult for older people or people who just don't have the right internet or video or phone access. Yeah, there's a couple of other questions, but I think they're really for the next, possibly for the next team. Yeah, national issues affecting local feedback, and that was another query. And I have to say, I do think it's been quite difficult for people to understand. Seems to me GPs have been focusing on slightly different things depending on, you know, what they've got in the way of buildings, how well they can ventilate. There seems to be a lot of confusion about getting blood test results in my area. So thanks anyway.
Thanks very much, Councillor Wood. And lastly, Councillor Daunton, please.
Yes, thank you. Thanks very much for the report. I just wondered how much evidence you've been able to gather on medication and prescriptions, and how great the difficulties have been in different parts of the county, and in fact where there's good practice and not so good practice. I'd really like to hear some more, something about the evidence there if possible.
Okay, we'll take a brief set of replies from Sandy, and then we'll move straight to Gary and Jessica. So Sandy first, please.
Thank you for your questions. I'll try and address these. So the report that I've presented to you is a collection of different reports that things that we've specifically looked into, and the intelligence that's been fed back to us. And it is quite clear, everybody in Health Watch accepts the fact that people that do have a negative experience have a bit more of an incentive to feedback. So there will always be a natural bias. It isn't, this is all qualitative work. So we're not looking for any sizable samples. What we are doing is we're collecting people's lived experience, analysing the themes that come out of that, and then presenting it. So we can present things in tables, but we're not actually saying this. A lot of this is supported by the larger number data, which the CCG I believe is presenting to you next time in the next item. So therefore, and that's the same with the service changes. I think the CCG deal with who's delivering what service. We didn't specifically ask the question. It was what people wanted to tell us. It's the voluntary feedback that we get from people. Indeed, the point taken about the way that that's presented in those bullet points. If you would like to look at the full report of the earlier report, it is referenced, and that is set out in a different, clearer way. And that was an audit of all of the websites across Cambridgeshire and Peterborough as well. So the next point about digital engagement is massive, isn't it? It's completely across all the services that we're hearing about. At Health Watch, we're really concerned about those people that are not digitally engaged, and CAMHS Online are fantastic. We're trying to work with them as much as we can, getting workshops together to get people just upskilled gradually, bit by bit, and raise awareness. And our AGM event this year, we had specifically on that issue. We haven't heard a lot about medicines. I think the CCG would be very pleased to look into that, because I know they have got an excellent chief pharmacist who works with us and comes out and talks to the community all the time. But medicines, apart from the issues about getting emergency medications, and sometimes there can be a little bit of the system breaks down a little bit when people are discharged from hospital, getting the meds that they've been prescribed in hospital, then in the community, that can be an issue as well. But we've always found the medicines optimisation group in the CCG have helped people resolve all the issues they've approached us about. So hopefully that answers the questions okay.
It does indeed, and thank you very much for your input, which obviously is valued by the members, and we regularly see you, and we hope and expect that to continue. Thank you very, very much indeed. So it's the same item, but it's 14B, primary care access. There is a report on pages 457 to 468 of the agenda pack, and we're joined by Jessica Borden, Director of Primary Care, the Medicines Optimisation and Out of Hospital Urgent and Emergency Care Collaborative. I got that one out. I don't know how often you say that.
Not often.
But at least it wasn't the big long acronym. And thank you for joining us, but also thank you and welcome to Gary Howsam. He's the chair of the CCG governing body, and whom we meet regularly in the context of the ICS preparations. Jessica and Gary are both joining us by Zoom, and I invite them both to present their report and to speak to us. Welcome.
Thank you very much, Chair. I'll just kick off with just a couple of, I'll take the report as read, but just a couple of points before we move on. So I think the first thing is just to say thank you to Sandy. So the intelligence that we get, we're working with Healthwatch really closely, is very helpful. And we're working on a number of projects around improving access and information and communication with patients and residents. So just a thanks to Sandy and her team up front. And I think we need to acknowledge that some people have had trouble getting access to their GP over the last 20 months, and I think we just need to acknowledge that is the case for some people. There are pockets of incredibly good practice, and there are some practices that have really struggled over the pandemic, and I think we just need to really be cognizant of that and know that we're working with them on that. You'll see in the report that actually our appointments are up on pre-pandemic levels, and some practices are talking around demand being about 20% up at the moment. So there is no let up in primary care at the moment. We've all had to change the way we work. Some people have done it better than others. And for some practices, for example, their telephony systems were just not strong enough to handle the number of calls that were coming in. And we're working on that and actually putting in some new telephony systems for some of those practices that have really struggled. And on top of all of that, we have been part of the vaccine campaign, which obviously is now having a reboost. And our practices in Cambridgeshire and Peterborough have delivered 600, as of yesterday, 692,000 vaccines, and out of 1.6 million in the area. And they really have contributed to the success of the vaccine campaign in that respect. So in summary, lots of demand, definitely some issues that we are working on. The paper sets out how we're investing more in, particularly around additional appointments and access, and also in additional workforce and a more mixed model of care, so that we can meet the needs of our patients in Cambridgeshire and Peterborough, but recognising that there are issues. And as the pandemic continues, I think we need to accept that pressures are still there within the NHS, and we do also have quite a tired workforce. I think we just need to understand that as well. So Gary, is there anything you wanted to add?
Yeah, thanks, Jess. So as well as being chair of the CCG for the last 5 years, I am a practicing GP up in Peterborough, and I have a national role with the Royal College of GP, so I can give some flavour of the national picture as well. But I just think reading this report in isolation is one thing, but it's actually really important to remember the context of the last 2 years. We've seen 9 million COVID infections across England and 127,000 deaths. We know that 90% of NHS patient contacts occur in primary care. And we also know that we've seen a large number of health workers die through the pandemic. So I'm not here today at all to defend what general practice has been done, but I would like to celebrate the work that they've contributed towards the pandemic. And I'm happy to draw out through questions some of the stuff that's also revealed in the GP National Survey, because that paints a picture that's somewhat contrary to what's often reported in the press. But I think there's two truisms that we mustn't lose sight of in this discussion. First of all, patients are struggling with access. And secondly, that GPs and their team are working harder than they've ever worked before. So it's not a case of which one is true, they are both true. And we're looking for the solutions to try and carry on providing the best service we can, whilst having again been asked to focus our attentions on delivering the vaccination campaign in the face of the Omicron variant surge, which is doubling at a rate of every 2 to 3 days, so is going to become an increasingly significant problem, and for which at the moment the vaccine is considered to be our best defence. So that's a context that we've been working in, but happy to answer any questions at all that you might have on how GPs are doing, and more widely the system, because looking at just one element of the system again deflects from the problem and the consequences of different bits of the system being under pressure. Thank you, Chair. Chair, you're muted if you're talking in the chamber.
Can you now hear me, Gary?
Yep.
Yes, thank you.
Yeah, great. We could hear all those presentations nice and clearly, so thank you very much, and you could be heard online very clearly. I anticipate there's going to be quite a lot of questions. We all care about our GPs. So if you could kindly write like mad as you hear them, and inevitably I think you'll have to bunch your answers up, but it is a sign of our interest and support for what you're trying to do. The first colleague is Edna Murphy.
Thank you very much. That's a really helpful presentation. I think the workforce issues are the impact of the pandemic are well understood, and we can imagine that. I wonder if there isn't an underlying workforce problem because of the sort of demographics of GPs, and without the numbers going into medical school to, as it were, replace those leaving the profession. I wonder if there's any intelligence that could be offered on that, because obviously then you'd have, with the pandemic on top, that could really exacerbate the situation.
Thank you. Councillor van der Ven, please.
Thanks very much for the report and for the detail and frankness of it. I wanted to ask about a couple of areas of support for general practice. I understand there's some good mentoring and going on between different organizations, and imagine that's probably a bit of a patchwork, but hope that that might be something that could be more greatly exercised. The question earlier on about other tests and services, I'm thinking about bloods at Newmarket Park and Ride, which I assume has been a big help. I don't know if that's actually for GPs as well as, is that just hospital, but outsourcing that sort of thing, getting those things out into the community, if there's more capacity for that. And I wanted to ask a specific question, which I've recently been learning about in a GP practice in which a local community hub is seeking to help with some of its non-invasive, you call it non-clinical, but non-invasive services. For example, health checks, things like that, that could be offered off-site. And it was described as a no-brainer. However, the bureaucracy around, well, the NHS bureaucracy, CCG requirements are so complex. And I wonder if going forward, you see some of these complexities being addressed and facilitated through what's coming ahead with the ICS. Thanks.
Thank you. Next, have Councillor Halley, please.
Thank you, Chair. As the lady from Health Watch was unable to answer my question, I'll probably just rephrase it slightly. Have doctors' surgeries been advised that there's certain procedures that at this moment in time they shouldn't be doing? Because my own local GP surgery, I know, are not doing face-to-face asthma checkups. And I know of at least one person who's been told she needs a minor surgical procedure and should be put down as high priority to be called once they are allowed to do minor surgical procedures. Is this a case for all GPs, or is it down to GP surgeries deciding themselves as to what procedures they are willing to do at this moment in time?
Any other members before I come in? Yes, please. Councillor Statter.
Thank you. It's a question about access, using online tools, but not perhaps as difficult to deal with for some people, and which might be better than hanging on the phone for hours. I know when we were setting up volunteer services locally, we explored these various things, trying to be as quick on the draw as possible whilst maintaining confidentiality. And that was what turned out to be quite simple, that you can get an online form via a website or via a QR code and put in that basic information at leisure get the bits and pieces of information you might otherwise have been asked for on the phone and you didn't have with you, and you get flustered if you've at last got through to the receptionist. So a calmer approach that can then be triaged in writing by almost anybody working online from home, having a bit of a break from the face-to-face surgeries, as long as you got the IT properly dealt with in terms of data protection. I don't know whether that was one of the tools that GPs are using, or even one that is being recommended by the government template possibility, but it does work quite well.
Thank you. And my own questions. Firstly, from the Healthwatch survey, I expected there to be more opposition to non-personal appointments by online or via phone. And a third of all appointments, you say in your report, are now not face-to-face. And I suspect, actually, that there are some people who appreciate the possibilities of doing that, as well as some people who really want a face-to-face service and are worried about getting access to it. I think there's probably an argument on both sides. What's your own perspective about that? And I've certainly heard in meetings with health partners that local GPs, surgeries have opened themselves up digitally to all sorts of inquiries by email and on websites that they didn't do before, but they haven't got the capacity, they haven't added capacity to be able to do that, and so they're finding it difficult to manage that. Would you comment on that? Certainly in Cambridge, the old out-of-hours service for access to GPs is now much more restricted than it used to be, and it's really difficult to get access to it. It's still very good when you get there, but it's really, really much more difficult, and of course it's been absorbed into the hospital. But what was the argument for doing that, and should that be reviewed at some point? Because of course that can take pressure off the emergency department. Thirdly, I think, and this builds on Councillor Hayes' question, I think she put an important question, but I think this is a public meeting and lots of citizens and patients are watching us online. Given the fact that the government has waived some of the obligations on GP surgeries to enable there to be more capacity to take part in the vaccinations, what's your sort of plain language message to local people about what they can't get that they would have been able to get before? I think it's important that we understand that. And finally, to Gary in particular, as I said, you meet with Susan and myself and our officer colleagues regularly in terms of preparation for the ICS. So I think it's good while we've got your presence here, just to, if you could say a few words about your hopes and any concerns about the primary care role in the ICS as we look forward to it being established. Back to Jessica and Gary, please.
Right, shall I start, Jess?
Yeah, you go.
Yeah, brilliant. So I'm glad I took the cue to write those questions down, because after 3 I'd have been panicking that I wasn't going to remember. But if I start from the top of the list I've made and work down. So first of all, the workforce problem. This predates the pandemic. There's been workforce issues in general practice for a number of years, reflecting some poor workforce projection planning on behalf of the relative governments over the past decade, and a lack of investment in general practice. What we do know is, if you look at the period between 2015 and 2021, there's been a 6% reduction in the full-time equivalent GP workforce, whilst we've seen a 4.5% increase in the population, which meant that the ratio of GPs to patients has swung by about 10%. We also know that over the last 10 years, people have gone from seeing their GP an average of 3 times a year to an average of 7 times a year. Even with no population growth, the number of appointments required would have doubled, and we've done that in the face of a dropping workforce. So they're long-standing issues. Major problems with retention, because the job at the moment is quite frankly undoable, and we're seeing people reducing the number of days they're working, although not necessarily the number of hours, as a mechanism to protect their own mental and physical health. We've seen a lot of people leaving the workforce because of that. There is some good news around workforce, in as much as we are entering more people to medical school and more people are going into GP training. We have a record number of people going into GP training, but that's not a solution for today or tomorrow. That's a solution for 5 and 10 years time. In terms of capacity, yes, there has been capacity issues. We know that across England, there were 34 million GP appointments delivered in October, which was 2 million more than in September and 7 million more than in August. So as I said at the introduction to the paper, the teams are working incredibly hard. In terms of services around occupational health and the like, and mentoring schemes, yes, there are mentoring schemes, but in order to mentor someone or be mentored, you need time and you need headspace for that to be beneficial. So there's some challenges there. There has been a national programme of occupational health extended to general practice and our teams over the last few months, and a lot of people are using those services, especially sadly in the face of the level of increased abuse that members of the GP team are facing. That's both clinicians but also our support staff, which I hope the committee would join me in condemning as totally inappropriate. In terms of other tests, there was an issue a couple of months ago nationally with blood test bottles not being available. That was nothing to do with Cambridge and Peterborough particularly. It was a national issue, but that created a bit of a backlog. And then the other issue that we have is that a lot of the chronic disease monitoring contractually obliges GPs to check bloods on a yearly basis. But the clinical evidence for that is quite weak. So people may have been used to having blood tests done on an annual basis, but there's been further guidance put out in the face of the pandemic saying it's perfectly safe for those periods of times to be extended. But understandably, people like what they've always had, and it's difficult to communicate those messages. The non-clinical services occurring off-site, yes, that would be possible. Unfortunately, all healthcare delivery is regulated by the Care Quality Commission, and a lot of the bureaucracy and regulation is due to their processes and is nothing to do with the CCG. What's been turned off? The news over the weekend, the Health Secretary and then through NHS England has made some very small contractual changes with the hope that that would allow some increased capacity for GP teams and not necessarily GP, but GP staff to get involved in the vaccination programme again. Someone was asking, is there a simple message? I'm afraid there isn't, because the ability of a practice to deliver will depend on the demographics of their population, the demographics of their staff, the quality of the estate that they're working from, and the needs of their patients. So what might be appropriate to turn off in one surgery would be inappropriate to turn off in another. The minor surgery element, that's actually an enhanced service. So that's out with the GP's core contract, and GPs are funded through an enhanced service to do that work. Quite frankly, at the moment, most of the stuff that we're allowed to do in general practice in terms of minor surgery is usually treatment of benign lesions, small lumps and bumps, things like that. And quite frankly, that's not high enough up the priority order at the moment, where we've got to make difficult choices as to where we add most clinical value. I'm afraid things like that will have to be parked for a bit of time. Somebody was asking about the other channels of access to GPs. So traditionally it's been telephone or face-to-face. There are a number of commercial products that have been utilised by practices across our footprint to allow people to consult by email or by filling out forms online. The issue with that, of course, is it just provides another inflow of work into the practice, and the issue is we don't have the capacity to deal with the channels that we had open already. So absolutely right, these are a good way of allowing patients to spend more time to articulate their issues, but it doesn't fix the problem of not enough people to deal with the demands coming in. The question around remote to face-to-face, I think the thing we need to remember is at the start of the pandemic, GPs were told that they mustn't allow people into their surgeries until they'd spoken to them on the telephone. This was because at the early stages of the pandemic, pre-vaccination, we were dealing with a killer disease for which we had no cure and very few effective treatments at the time. And by keeping people away from surgeries and conducting an initial triage call with them helped to keep the patients, most importantly, but also our staff and the doctors and nurses safe by reducing social contact as we did in many other areas of our lives. We're back up to a ratio of about 2/3 being delivered face-to-face and 1/3 being delivered remotely. And as the questioner suggested, there are proportions of the population that find interacting with the practice in that way particularly helpful. I know the demographic that I look after in my practice, a lot of them are on 0-hour contracts. So if they take a morning off work to get an appointment and then come in and see me, they lose half a day's pay. And if they can transact their healthcare needs through the telephone whilst not missing any work, then that suits them. But ultimately, the pendulum swung very much towards remote care as early days of pandemic, and it swung back. And I hope in the future we'll have a blended offer, and that will be decided between the clinician and the patient according to needs and wants and the context of the safety in which that care can be provided. The comments around out of hours being more difficult, actually it's much easier in terms of getting access to the GP out of hour service now because it's all done through the 111 service and people are directed to the GP out of service. Yes, there are capacity issues in there, but it's wrong to say it's being consumed by the hospital. GP out of hour services are provided by a third party that is contracted, commissioned by the CCG to provide those services, but it is staffed by GPs. One of the sites is within the footprint of the hospital, but other sites exist and visiting services are obviously out with the hospital. I've got no simple message. Yeah, that was to answer the what's going to be turned off. There isn't a simple message. I think the message I would want to give out for patients is to understand that if you take what we would normally be doing as what we call business as usual, we're also dealing with looking after the 5 million people that are currently sitting on hospital waiting lists. And the National Audit Office have suggested there's probably a similar number of people that are yet to come forward. So they all have unaddressed health needs, which primary care are looking after. We're delivering the biggest flu vaccination campaign in history. We've delivered about 75% of the COVID vaccinations, and all this in a context where our staff are struggling, as with many other organisations, with both physical and mental health. And if I could just finish with some numbers from the National GP Survey. This was conducted in July of this year, and 83% of people had a good experience overall of GP practice. 94% had their needs met at their last appointment. 68% reported finding it easy to get through to the practice on the phone. 82% were satisfied with the appointment offered and they accepted it. And 70% were saying they had a good experience of making appointments. So I'd love to see those numbers higher and closer to 100%, but I think in the context that I've outlined with all the additional workload and workforce pressures, I go back to the point I made in the introduction that I'd actually like to celebrate everything that primary care has been able to deliver alongside our secondary care and community colleagues throughout this pandemic. It has been relentless. And I don't think anybody in the health service would be able to recall a time where they've worked harder under more difficult circumstances. So yes, work to do, always very keen to hear about how we can improve, but let's not lose the point of the fantastic work that the NHS has allowed the patients and residents of Cambridgeshire and Peterborough in dealing with what is historically the most significant challenge to public health ever. Thank you very much.
Jess, we are behind on time, but it's a really important issue. Please do add anything that you wish to add.
I don't really have anything to add to that. I think that's a really good summary. I suppose just on 111, which I always look after, their demand is up 40%. So we are challenged and doing our best and delivering really good care in really difficult circumstances. And the people need to be seen, they will be seen. And I think that's the key message to take away, really.
Thank you very much. I'll politely disagree with you about getting to the out-of-hour service 3111 and how many calls and assessments it takes before you get there. But generally, as I think all of the health partners who are watching know, that we regard our strategic function as not here to sort of bash you down, but to really listen to what you've got to say and to see how that can inform our joint work together, as well as obviously to represent the public interest. You know, Kate Parker, who, as everyone in the room knows, arranges these sections of our agenda. She is listening online. We'll be drawing up a full note so that we can reflect the different questions that have come forward, and we hope that feedback will be useful to you, Gary and Jess, as well as undertaking our role. I do want to thank the whole primary care partners for what you're doing in the pandemic. I think you said it right at the beginning, Gary, but I think we're extraordinarily appreciative of everything you're doing, and I want to put that on record. When you say the job is undoable, that's obviously a challenge for us all, but we recognise the pressures that you and your colleagues are under, and I have no hesitation in condemning issues of abuse against GPs, your staff. Also, I have to say, in vaccination centres, you know, we all have to wait a bit longer sometimes in emergency departments. We all have to wait a bit longer sometimes than we like. But then when we see our health providers, we understand the extraordinary pressures that they're under. And there is no excuse for lack of courtesy or any insensitivity towards the people who are providing the service to us all. So I absolutely say that. So we will write up the conclusions. Gary and Jess, thank you so much for joining us. I will just also welcome Councillor Garvey from South Cambridgeshire, who joined us during the course of that debate, and like Councillor Wood, online. And I think we may have another of the councillors that I can't read at this distance, I'm sorry, but all of our city district councillors, just raise your hands if you wish to put questions during the course of the debate. And I do think we've had apologies from Councillor Sarah Wilson, which I should record. But that then completes item 14, and thank you again to Gary and to Jess and all your colleagues, through you to all your colleagues, for the contribution that you're making. Next, we move to item 15, the Cambridgeshire and Peterborough Foundation Trust Occupational Therapy Service and its waiting lists. There's a report on this on pages 469 to 474 of the agenda pack. I should have thanked Sandy Smith as well, who may still be with us. If I didn't, I'm really sorry, and someone perhaps could pass that on. But what I would like to do is to welcome Ashton and Tully, who's the Service Director for Older People's and Adult Community Services in the Cambridge and Peterborough NHS Foundation Trust. He's joined in this discussion with our own Commissioner, Diana Mackay, who's responsible for early intervention and prevention within the authority. So Ashton will lead on this, but Diana will also be available to answer questions. Ashton, thank you for your patience in waiting. I invite you to address the meeting.
Thank you very much, Chair. And can I just note as well, I've got a couple of colleagues with me on the meeting today. Eileen Nixon and Anime Vanning, who are here from a service perspective, who may be able to help assist if we have any questions that relate that are service specific. But certainly happy to take a lead, and Diana should be joining us shortly from the local authority commissioning team to support as well. Just a bit of background in relation to the occupational therapy service. So we deliver this within CPFT under a Section 75 arrangement with the local authority. I'll take generally the rest of the report as read, and I'll touch on key highlights within that report. We deliver that service as an integrated function within our CPFT community services in the neighborhood teams. So working very much as part of wider multidisciplinary teams in the community. The focus very much for our occupational therapy service is to ensure that we're providing assessment all the way through to rehabilitation, really with a focus on enabling people to remain at home and facilitate and improve independence within people's own homes. We also within the occupational therapy service work quite closely with other system stakeholders, including social care and other providers. So there is the home improvement agencies that we work alongside as well, including also supporting for those individuals who require support from the Disabled Facilities Grant within the communities. There are, just to highlight in terms of the kind of grant support that's currently available, that it's capped, I understand, at £30,000. And we have had some feedback through the home improvement agencies just around the challenges this does bring as well, in terms of usually the costs are much higher, and therefore there needs to be further steps taken to support individuals access funding, particularly where it involves home extensions. So that usually will lead to longer waits and increased delays as well. I just wanted to touch on the CPFT aspect in terms of where we are with the waiting lists. So at the start of the pandemic in 2020, there was a real system drive within Cambridgeshire and Peterborough to support building capacity within our acute hospitals. So there was a significant redeployment of staff to support our discharge to assess pathways, which very much are focused on supporting flow from our acute hospitals into the community and ensuring that we could get as many people out of hospital and to support those at home. So that was in March 2020, where we redeployed a significant cohort of staff. They returned to their duties in August of 2020, with a further redeployment in December 2020, when we had a second wave of COVID. We did return, so all our staff were redeployed, returned to their normal duties from April 2020, which is, 2021, beg your pardon, which is when we began focusing very much on addressing the waiting lists that had built up from the first wave where we redeployed staff, and then the kind of second wave, which caused additional waits really in terms of from patients and people would have been accessing occupational therapy services at that time. During that time, we continued to focus on urgent referrals. So anyone who needed urgent interventions from occupational therapy continued to receive that support. We had a process in the system for supporting and managing waiting lists. So all patients who were referred to the service were triaged, and they would have their needs assessed and prioritized accordingly. They'll be placed on a waiting list. We would then write to those patients to be able to indicate what to expect while they wait, but also what to do if their needs changed. For example, if their situation deteriorated, they could contact the service. We would re-triage, move them up the priority list, and be able to see them urgently if that was the case. There was also virtual and digital solutions that were employed to ensure that we continue to support patients during this time. So we have used our Attend Anywhere digital solution, which enables virtual contacts with patients while they're in the community. I just wanted to touch on there's a chart that you will see there that shows the waiting lists over a four-year period. And it shows for sort of our waiting list from 2016, and you will see certainly from around early 2021, a significant increase and spike in those waiting lists. And that very much correlates with when we had the wave 1 and wave 2 of COVID, and then the increased waiting lists of those. The chart will also show in the kind of darker color at the top, which is very much an indication of those now currently waiting 18 weeks and over, which again, we saw that, as I say, continue to increase during the period of lockdowns and first wave and second wave. In terms of just quick summary numbers from a waiting list perspective, our waiting list pre-COVID were around 538 cases. We saw a growth of around 126% of those waiting lists during the period of redeployments. So those waiting lists grew at that time from 538 to 1,217 cases as a consequence of the direct impact of COVID and the steps that we had to take to support the system and redeploy staff to support really huge efforts that were being undertaken across the system in terms of to support, to keep people well and safe and really have good flow out of our hospitals, as I've indicated. Our total waiting list for 18 weeks, as I've touched on, again grew. We had 0 at the point when the pandemic began. Those grew to about 296 as at the end of September. All these cases we continue to proactively triage and manage and support individuals on these waiting lists. The average waiting times currently, so pre-COVID, we had waiting lists that were around 3 weeks. Those waiting lists grew to about 10, just over 10 weeks, 10-week waits. As of September 2021, the longest single waiter on our waiting list was at 35 weeks. I had a look at this for last week, and our current longest waiter is at 29 weeks. So a slight improvement on the 35-week wait for in terms of those kind of single cases. However, on the whole, we continue to work really hard with our teams to support, and retriage and focus on reprioritizing cases where there is need to do that. In respect to what we're currently doing in terms of service-specific actions and mitigating steps that we are taking as an organization, working quite closely and in collaboration with our commissioning colleagues within the local authority, is that we very much review and report on our position on a monthly basis through our formal, performance and finance meetings that we have, as well as other groups that our commissioning colleagues support. We see all agent referrals and we try and make sure that they have an intervention within 72 hours of referral. While all routine referrals will naturally go on the waiting list and be triaged appropriately, and as needs change, we'll reprioritize those to ensure that we deal with their needs as quickly as possible. As I said, all services would have received a letter explaining what to expect, but also how to get in contact with the service. And there remains those kind of retriaging, functions that are designed to, deal with, moving people up that priority list if their needs change, and ensuring that we're able to respond to those changing needs. We are looking at different initiatives at the moment to support our teams and release clinical time. So a number of our staff continue to work extra hours to support the team doing, additional bank hours. We continue to look at options to use agency staff as well. It's just worth pointing out that it is a real challenging environment at the moment, workforce-wise. So although we do take all these steps, we usually are calling on our existing staff who have been really working very hard during the pandemic and are tired, are fatigued, are exhausted. We recognize there's a risk of moral injury also where staff are concerned. However, it is really a challenge to secure agency staff out there. Not that we are doing everything that we can to also look at other options, including going off the framework of the agencies that are approved, but there is just a lack of workforce. And therapy in itself is a challenge, not just for CPFT, it's a recognized challenge for us as a system at the moment within Cambridgeshire and Peterborough, and an area that is clearly challenging nationally in terms from a therapy provision perspective. So we are looking at alternatives on how we can mitigate that and address that. Our organizations have recently had some health education support funding to look at workforce leads, which we've successfully recruited to in the last few weeks for CPFT, and I know other organizations in our system have done that. So we are working as a system to consider and look at how we can really address the issue and the challenge around therapy workforce provision as well. We are also looking at an option to outsource some of our waiting lists to NRS, who also provide another function in terms of equipment support within the community. We have got internal support for that within CPFT. We've presented that to our commissioning colleagues within the local authority. There are still a few questions that we need to work through from a governance perspective and assurance perspective to be able to then get formal authorization and support from the local authority. So we are working with that provider that we're looking to outsource to to answer those questions to make sure we've got the right level of assurance for us to be able to do this safely and effectively. That's where I will stop at this point, and I'm happy to take any questions. Hopefully my colleague Diana from the local authority has joined as well. She may be able to support, answer any questions that you may have. Thank you, Chair.
Thank you. I think Diana might be listening, but for time reasons, we've got about 15 minutes or so on this. So if she is listening, we'll invite her to help answer the questions, but move straight to members' questions now. And Ashton, I think you were present in the previous session. If you could kindly take a note of the questions and then deal with them all once at the very end, I'd be very grateful. I've got 3 members at the moment. Councillor Daunton first.
Yes, please. Well, first of all, a comment. Thank you very much for the paper. I mean, we know that, that the long waiting lists do have a huge impact upon people in their homes and really can reduce the quality of life in people's homes. And I mean, I know that you accept that, but sometimes it can have really devastating effects because housing officers are dependent on the assessment. But I know that you've been very upfront about that. But my question really is to do with the reference on page 473 to the proposal for outsourcing 250 cases on the waiting list to an external company. So have you got any idea of why people are willing to work for an external company rather than within the system? I mean, what is it? Is it flexibility of working hours? Is it pay? Where are the issues?
As I say, could you answer all the questions at the end, please?
Okay. Yes.
So sorry, but it's just about enabling as many questions as possible.
Absolutely.
I will try and make sure you've got a good time to respond now, because obviously that's the point. Councillor Van de Ven.
Thanks. It's very sobering to see your waiting list, of course. And as one of our colleagues mentioned this morning, CPFT is a really perfect example of our partnership working and integration, you know, in every single way. I did want to note thanks for Diana Mackay. I didn't realize she was I didn't know whether she was Cambridgeshire or CPFT when she intervened on a piece of casework, but how helpful it was just to make a call to someone to explain how the waiting list works and that minor interventions are possible in the meantime. The workforce issues, I think it's probably worth noting almost in every item that we're dealing with that this scrutiny committee has been questioning and trying to understand workforce issues for many years. And they do predate the pandemic. And I just wondered if you could say a little bit more about recruitment. You did mention it at the end of your report, but what additional initiatives and I'm sure it's a long process, but any additional insights, and of course that complements the question that you've just had from Councillor Daunton. Thank you.
Thank you very much. Councillor Slatter, please.
Just trying to edit my question because part of it's covered already, and the councillor mentioned the fact that you missed perhaps this morning my delight in finding there was a qualified OT over the table as part of our social services, and that clearly works really well. Starting to look at this report, I feared that we might find that there were unnecessary blocks where you wait for hours, well, sorry, wait for weeks for an OT and find you could have bought it in the shop. But obviously there's very intelligent management of your waiting list, and you are trying to deal as much as possible by just saying, well, you can go and get that from Amazon. It's perfectly sound. You don't need a fully qualified OT. And obviously careful use of the fully qualified people is really key to so much of what we do. I think we're going to come across that with the library working party as well, aren't we? Obviously, you're working along all the right lines, we would hope. But Susan has just mentioned the possibility that councillors could do with just a little bit more guidance on how the system works. And then they, in turn, can deal with the really distraught resident who's been waiting for months for something on the OT system and is on a waiting list, doesn't know why. And maybe there are things that can be done to bring them up the list. They've got the letter, it's tucked behind the toaster, they haven't read it lately, and they'd forgotten the bit about getting in touch again when they lost the use of the other leg. I'm not taking this lightly, but that is how sometimes our legs work. And so that would be really useful if it's worth putting a little time into a dummy's guide to the OT waiting list system as run by your trust. I'd really appreciate it. Thank you.
Thank you very much. Councillor Wilson.
Thank you, Chair. I wanted to make 2 points. One is, should the County Council be doing more? How can we as members help you on that? You talked about waiting on the outsourcing for the County Council commissioners, and is there anything we should be doing? And then the second question, and you've been very honest about the waiting list and how long people wait and how many people are on it, but you don't actually explain what the impacts of being on the waiting list are for individuals. I think one or two of us know from casework, but it would be useful to know whether or not that's really a problem. And because there are more people on the waiting list, there are more falls, which is creating a greater workload for other people elsewhere. Thank you.
Thank you. And from me, like Councillor Wilson, I'm really grateful that you've been so open and transparent about the challenges around waiting times, both in terms of numbers of cases and the length of waiting. Realistically, do you have targets on when you're going to bring those down, or are we going to have to live with them? So we're not just commenting on those figures, but your plan to manage those figures. Do you have any specific targets and timescales? Secondly, I'm sure that the challenges that you've got are not unique to Cambridgeshire and Peterborough. So if you benchmark the challenges that you've got against other similar authorities, where do we stand, or is this a common problem? Thirdly, clearly the OTs play an absolutely crucial service in terms of hospital discharge, which has to be time critical in a small number of days, not 18 weeks and above. How do you balance the pressure to do that very urgent and immediate work to enable the hospital discharge to take place against the longer term work and making sure that everyone gets as fair access to the service as possible? And lastly, in the report you talk about an increasing pressure of affordability and that the sorts of adaptations that are needed in people's homes are above the threshold. Could you comment more about what a challenge that is for people and what could be done about it? And can I just apologise for Councillor Wood, who I think did have her hand raised and then I didn't see it before starting to speak. So those are my questions, but I will go back to Councillor Wood before I go back to Ashton. Councillor Wood.
I think you've actually covered what I was going to say. Are we getting hospital discharge delays at all? I know you know that is the highest, that's considered an emergency and charged the highest. I'd be really pleased to see, I'm pleased to see that you're communicating with your service users, clients, patients, but as a counsellor, I too have been in the position of Councillor Daunton, where I'm having to try and find my way around the system with service users, residents with issues. How is it going with the HIAs? And how are we performing locally compared to the national picture? And of course, the other thing is the workforce and how you're managing that. But I think Councillor Howard, you covered what I wanted to say. Thank you.
Thank you. Diana Kai is there as well. So I'm going to Ashton, I'm going to ask you to speak first, then Diana to add another thing when you've finished. Ashton Nuntally, please.
Thank you, Chair, and thank you for all those questions. I will certainly bring in my colleague Diana on a couple of those, and possibly Anime on one of those. I will start with the first question in terms of probably the first two are connected in a sense. So looking at the outsourcing and the proposal. So NRS, we understand this is their core business, and they do this. So we have been looking at, with the current challenges and with the current waiting list, really looking wider as in what other organizations deliver similar functions or the same functions as independent, private providers that we could call upon that specialism to try and help us make a significant, dent on some of the weights that we've got. So I understand for NRS, who we're looking to outsource to, this is essentially their core business. In terms of recruitment, it is a system, therapy workforce is a system challenge. Certainly something we've picked up with our allied health professional leads within the system, but also within the region. So the allied health professional leads within the region fully recognize and are supporting with initiatives to look at how we can address some of these challenges in terms of recruitment and how we can attract, the right, staff to come and work within our system. So, and very much we are having conversations at a system level, recognizing that, if we try to fix just a CPFT issue, it leaves challenges elsewhere. It leaves challenges for acute, providers, or if we look to just recruit a CPFT in an uncoordinated way, we will most likely be, stealing from, robbing Peter to pay Paul. So we will be, either recruiting for our existing, partner organizations, which will still leave challenges within our system. We have been having conversations around also considering international recruitment as an alternative, particularly where therapy is concerned. This has been done quite successfully in nursing, in nursing roles. It hadn't been explored in the same fashion, same level of detail, certainly with respect to therapy. This is something we've been having internally within the organization, but also some things we've raised within other forums at a system level to look at what other options we can have. There are apprenticeship programs that are currently out there, so we are constantly promoting those as well. In terms of, because apprenticeships, we need, I think, as a system to also look at how can we grow our own workforce. I think that's a really crucial, part in terms of thinking, in terms of how we develop, workforce for the future to be able to deal with some of, the challenges around recruitment that we continue to see. So it's not easy, but we are working, as I say, really hard to look at how we can prioritize that. And there's something that I've raised with our executives, and certainly I know system colleagues, are fully involved in those discussions. And we have, as a system, identified that as a priority in terms of addressing, therapy workforce issues. As I say, that's led to these new roles that are looking at therapy workforce being recruited to in the last couple of weeks. Councillor Slater, thank you for your comment just around the guide to waiting lists. We'll pick that up with my colleagues, and we'll definitely develop something that we can share that's hopefully easier for people to, I do appreciate, letters do get lost and things will go missing after a period of waiting. So we'll run through a simple guide that can, be communicated and shared widely. So we'll take that on board. Thank you. In terms of Councillor Wilson, thank you for your question as well. In terms of what the local authority can do in terms of supporting us further, we are working really, really closely with colleagues in, as I said, in the commissioning team to understand where the issues are, where the challenges are, but also in terms of finding solutions. Really looking at this in partnership and the system. So on that regard, I do think that we have the right level of engagement and the right level of support, and we continue to, openly and honestly, review where we are and what the challenges are, and considering what options and solutions we can employ. The waiting for the NRS, finalization. Just to clarify, we are not currently waiting on this from our local authority colleagues. they have come back to us with some questions that we needed to answer. We have gone back to that provider to clarify those points of assurance that our commissioners require, because we need to have absolute assurance and provide absolute assurance also that if we are looking at outsourcing, we have considered all aspects of how this will work. And if there's any additional questions, we need to work through those and make sure that we have a fully robust, plan in place on how we're going to, operationalize and manage, the outsourcing, of these. So that's something that we are, we're looking at. My team and my colleagues are having a meeting with NRS to be able to pick this up and progress this. I'm hoping we'll be able to have those questions answered in the coming days, and hopefully we'll revisit them again with our colleagues in the commissioning team. In terms of timescales for the waiting lists, our timescales are really challenged by the changing position within our system. So we had looked at our outsourcing very much focusing on those longest waits that we categorize as priority 3. The urgent ones we continue to really pick up within our service as it is now. So we would be looking at prioritizing those longest waits, which are the lower priority in terms of the categorization of those waits. We are looking and just watching also in terms of the anticipated impact from the recovery of electives when the local authority, the acute hospitals start picking up the activity on those, because that we anticipate would have, create further demand for our services, and therefore any projections we would look to make would be directly impacted by that. So we were looking at how we can really look at the longest waits as a priority focus piece of area with the outsourcing work. And then we would look to, once we understand the recovery of electives from the acute hospitals, I think that will enable us to understand the demand and therefore what the impact on the waiting list will be longer term. But hopefully, those electives at the moment, we haven't fully done that piece of work to understand what that throughput will be coming through from the recovery within the acutes as well. In terms of where we stand, this is, as I say, the challenge is not unique to us from a workforce perspective. The challenge is certainly across a number of organizations in our system. It is a challenge within the region, and we are certainly hearing that it is a pressure in other parts of the country as well. But we are working very closely with our regional team. So one of the chief regional AHPs has been working in another part of a role within CPFT, and we'll be working fully within the region as of the next couple of weeks. So we have got, as I say, the right, interface and engagement with the regional team to continue to support and work with us on addressing the workforce challenges for our system and the region as a whole. The balance between discharge from hospital and community, I probably needed to clarify that the community element we've presented today sits separately from the support functions for discharge from hospital. So we support discharges from hospital through the discharge to assess pathways. So they sit quite separately from the community provision through the integrated neighborhood teams. I will bring in Diana if I can to probably touch on the question around affordability, if possible. And we do have a pilot for Councillor Wood's question just around how we work with the home improvement agencies. There are a number of challenges, and there's a lot. There's a pilot currently in place around trusted assessments as well, which is due to be reviewed this month, I think, Diana. But also there's the additional impact of availability in terms of from a kind of the improvements that need to be made in people's homes. There's delays either due to things being delayed at ports in terms of equipment that's needed to be able to complete these improvements. So that's another challenge for our system, that there is these delays, which we've seen in a number of areas, I think, nationally, and we've heard about certainly in terms of things being delayed or being held at ports of entry, and that does impact, the industry in terms of how effectively they can do those works. Diana, I'll bring you in at this point if there's anything you can help. Thank you.
Thanks, Ashton. That's fine. Pick up of the queries and points. One thing just to reassure the committee is that the Section 75 agreement that we have with CPFT is very comprehensively managed and monitored through a number of different governance forums now. And I'd also like to offer some reassurance, and this relates to the cases that end up with the home improvement agencies, is that what CPFT do, because they are a wholly integrated service, they will very much address urgent and high risk needs first before people are placed on the longer term waiting list. So to give you an example, if that would be, someone is needing a lift, perhaps a full-time wheelchair user, or somebody on the verge of full-time wheelchair use, or they might need a stair lift, for example. Those are major housing adaptations that we would refer, or CPFT would refer through to home improvement agencies to apply for a DFG. And those are the things that are taken on as safely as possible on the ground floor through ground floor living. It may not be ideal to absolutely appreciate that, but that is what sometimes has to happen while people wait for that longer term major housing adaptation. But equipment is provided, and management techniques, rehabilitation techniques, if they're appropriate, are and goes on the waiting list. So I hope that gives some reassurance to members of the committee. As Ashton has alluded to, the community equipment service and the contractors that work for the home improvement agencies are all facing the national and global challenges that we are all seeing in relation to all sorts of commodes, hoists, stair lifts, etc. They are all A, getting extremely expensive, and B, because of the world trying to get back to normal after the pandemic, there's been an enormous call and pressure on those sorts of materials. And so we're seeing real pressures in those areas, but it is easing. Ship and things like that. And the cost of containers and pallets and all of that, prices are going up, and has affected everything, including our services, particularly the equipment service and the adaptation service that the home improvement agencies run. I hope that I'm happy to take any other questions around that.
Sadly, we've run out of time. Just to yourselves, but also to those watching us online live. Again, we got 90% of that. I apologise for some of the slight loss of sound, but your meaning was very, very well conveyed, and we were able to hear it properly. So thank you very much, Diana. Thank you very much, Ashton. As with the previous item, we'll be writing up in detail these exchanges, and we hope those will be helpful to you, as well as fulfilling our function.
Thank you very much.
Thank you again, Diana and Ashton. But I'm just being advised to my right. Let me just check I've not done something wrong. I'm now with you. I think I can't read the name. I'm really sorry, but Ashton, one of your colleagues has also been there listening carefully and supporting you. And to that colleague, I think it might be Anna Marie.
Thank
you for smiling back. But yeah, we obviously value all the colleagues involved in the occupational therapy service. We thank you, and we wish you the best of luck.
Thank you.
We now move to the last substantive item for today, which is the exchange with the East of England Ambulance Service. That's item 16 on our agenda. Pages 475 to 484 of the agenda pack. And I'm really delighted that Marcus Bailey, it's a bit dark at the back. So again, if Nick in the sidelines could help these sessions are about shedding light on issues. So I think we need to shed some light on you so that we can see you, especially as you've taken the trouble to come here and be physically with us. But can I introduce to the committee and warmly welcome Marcus Bailey, who is the Chief Operating Officer of the East of England Ambulance Service. His report, as I say, is presented to us at pages 475 to 484 of the agenda pack. And I'm delighted that the lights are on. We now get to hear from you, Marcus.
Thank you for that introduction, and I do appreciate it and the time given to be able to meet today. I was just going to give a kind of a brief summary and current position, and then allow conversation and questions, if that's okay, Chair. So, as I said, thank you for allowing me to attend today. Clearly, we attend in the run-up to the festive period, but a very busy period that has not stopped for us throughout this entire year, and we're now 2 years into COVID. What I'd probably just like to just highlight from our point of view is just a couple of areas related to current activity, just to set the context a bit more from the report when the report was submitted to the committee. So we know that we have maintained our highest escalation level as an ambulance trust, and this is replicated across the entire English ambulance trust, which is REAP level 4. This identifies that we are under sustained and continued pressure on a variety of areas. That includes physical responses to patients, amount of 999 calls coming in, the pressure at acute hospitals in handover times, and also acknowledging the pressure that our staff have been under and resulting and relating into sickness absence with our staff as well. So we move into now delivery over winter. It is an escalated level. We knew that COVID is not over. COVID had not gone even before the latest announcements, and we've been planning very much about the effect of that across both the ambulance trust and also sectors as well. As I said, I'm not going to take up any more time with just me introducing, because I'm sure committee members would like to ask some questions as well, but hopefully the context of the current picture is really rolling on from when we put the support, meaning that all of our services remain under continued and sustained pressure. Thank you, Chair.
We know that you've had some really big challenges and dealing with them, and we hope that today's debate can also assist and support you in meeting that. And I know a number of members, as in the previous section, so I think you came in and witnessed some of will want to ask questions. If you could take a note of questions as they're put, because there'll probably be quite a lot, and then we'll give you ample time at the end to be able to answer them all. Councillor Goodliffe is the first to ask, please.
Thank you. Thank you, Chair. May I ask about the Ofsted inspection and the apprentices programme? So initially, how are the 661 apprentices who were involved in the programme, and is their education and work placement still continuing? And how is the implementation of the robust action plan that Ofsted mentioned should be put in place going? And is there an impact of the new support processes that have been put in place since that inspection in June? And can you just give us an update, basically? Thank you.
Thank you very much. Councillor Corney, please.
Thank you. And thank you, Marcus. Thankfully, I haven't had to call on your services for some time now. I know that when I have done in the past, it's never a more welcome sight when you obviously need them. I'm always blown away by the sheer volume of calls that you deal with when we see these reports. But what saddens me is that reading 271 about body cameras that are coming. That's something that's coming forward. It's quite sad. Obviously the reason behind that. Just intrigued to know how much time, what cost that has. Of those incidents to the service. And we're sort of seeing that we've got a rollout already in June at one place. We say it's rolling out here as well. Is that imminent? How close is that? And hopefully have an impact. But like I say, one incident is obviously too many.
Thank you, Councillor Corney. Councillor Howell, please.
Thank you, Chairman. With regards to page 476, you put in there with regards to the 178 actions, the CQC report, 69% are complete with a further 18 rated green or green amber in terms of confidence in delivery. With regards to the remaining ones, is there anything that we can do as a county council to help, or any other council can do to help? And which ones would you like us to be aware are very challenging and going to be a bit more time than you would like, but you understand that that's what the case? Thank you. Thank you, Chairman.
Thanks to you. Councillor Van de Ven.
Thanks very much for your report. I wanted to ask what more can be done at a community level, and perhaps I'm thinking of our enhanced response service to help avoid unnecessary calls to your service and admission to hospital. Thank you.
Concise questions, but big questions. So we look forward to your answer. Councillor Wood, please.
Thank you, Councillor Howitt, and thank you to Mr. Bailey. Can I ask firstly about staffing and staff turnover? I note that you've talked about this stopping of late finishing. I'd love to see a table or for you to comment on how we're performing. It's the figures nationally, and whether there's a big seasonal change. I think there is from what you're saying. I did wonder, when you're talking about using data more, this is the Ofsted recommendation on using data more effectively to look at how staff groups. Do you monitor age and ethnic group? I assume you probably do. Then I had some questions on so this is 263. Yeah, what is the impact of being at REAP 4? It sounds from what you just said that nearly all ambulance trusts are now at REAP 4. Is it something you end up being almost at permanently? And ambulance turnaround times 266. Yes, of course, I wondered if you could comment on that and working with our acute hospitals. And then on 273, yeah, I wasn't too clear quite what the co-responders do, so I'd love to have a bit more information on that. And also on 282, and that's about support service teams returning to offices or a hybrid approach. I mean, I take my hat off to your staff to be able to do this job if they are working from home. Yeah, use of private ambulances, so that's 291. How much do we rely on these, and who and where? So those are my questions. Thank you.
Lots of questions there. Thank you very much, Councillor. Yeah, but very relevant, and we're doing our job, and I know that they'll be welcomed by Marcus. Anybody else before I come in? No. My one's, sorry, I've missed someone. Sorry, Councillor Slatter.
Yeah, it's a tricky one, and it's nice to eyeball you. I raised this with social services as well, and I was very pleased with how straightforward and open they could be in their response. There'll be some people, end of life, who actually don't want to be taken off in an ambulance, and sometimes, as we know, they actually die in the ambulance, and they could have died in bed, and that's what they wanted all along. Now, I've seen two of my parents go through this, and we've always made sure there was the proper letter from the GP telling you about do not resuscitate. Now, I know this is a difficult area, but I don't think we should avoid talking about it when it can make a big difference to the way somebody leaves this life. And that is crucial both for them, their family, and for you. because in these times of COVID, I'm glad my parents didn't have to go through COVID, they will not have company other than that of kindly and compassionate strangers. So it's more a question of, do you find that the public are aware enough of the need to have something like an advance directive in their home, in a file that other people are aware of? Is there a way that we can help to publicize that service and the work of some of the charities such as Compassion in Dying? And would you welcome that, or is that something you really don't feel is your job?
That's another big question, but thank you for putting it, Councillor Slatter. Some from me, and then Marcus, it'll be for you to reply. The first one is, as I said in the introduction, everyone knows the East of England Ambulance Service has had some extraordinary challenges. That you're being quite open and transparent about that. I read the interview with your new chief executive. I know you've got a record low in terms of response time in the last month. And he says that things are going to get worse before they get better. And I think it's incumbent upon us to recognise that challenge, to thank you for the openness and transparency, and to give our commitment to supporting and working with you in any way that we can to support some very difficult actions that are taking place. I say that at the beginning. I will also say that for the members of the public watching, that old concept of the ambulance being essentially transport to hospital is not what it's about nowadays. It's about the role of the paramedic. And when I've ever had personal interaction experience with your staff, I've been amazed by their skill as paramedics in actually dispensing treatment, not driving vehicles. And I just want to place on record my deep appreciation for that. You've clearly got a problem at the moment of the sickness rate, which is nearly doubled. I've read what you're trying to do in terms of mental health support, but clearly your colleagues are really suffering at the moment, as many health service colleagues are. I just ask you to comment a bit on that, because it's obviously a very, very relevant issue. We all know, I think it's been referred to in other questions, but it's not your fault if your ambulances are lined up at hospitals, but other trusts in the country are working hard with hospitals to try and avoid the queues and avoid people dying in ambulances. And so if you could say a little more about what you're doing with our local hospitals together to try to deal with that, I think that would be really important for us to hear. I know that elsewhere in the region in Norfolk that you've introduced a mental health car so that mental health cases can be dealt with differently and better compared with the generic cases that go to the ambulance service. Do you have a similar facility in Cambridgeshire, or is that something that you're considering undertaking? And finally, on the issues of racism and the report of the Equalities and Human Rights Commission, I know that you've dealt with over 100 cases already, but there are, I think 71 cases last I read that remain unresolved. You referred to that in the report and in other public documents, but you don't really refer to the content of how you're dealing with it and the outcomes. We're just seeing numbers of cases dealt with. Clearly, we don't want you to describe any individual circumstances or cases, but could you talk a bit more about what you're finding and what lessons are coming from that? Because obviously that's an area of high concern, I'm sure, to you and to all of us. Those are my questions. There's a lot there for you to chew on, and I thank you very much in advance for your answers.
Thank you, members, for the wide-ranging questions, and please, I have tried to scribble over 3 pages, so you will please correct me if I have not captured them, because they are all excellent questions and some good discussion or thoughts that I'm able to share in terms of where we are, so I appreciate that. So if I start with Ofsted, so really good question, how are they? And it's one of the approaches that we took very early on. I was very keen that out of all of this, was it a surprise about Ofsted per se? Yes. Was the content a surprise? No. Was the focus needed on learners? Absolutely. And I think the emergent discussion now as we move forward has been very much about when a service is under pressure, when you have the cultural challenges, when you have a significant amount of learners. So to put it in the context, when we look at our BSc paramedic science students, we support our own learners internally. We're talking about 1,000 people in learning. That is significant from a frontline ambulance resource that I have in people of around 3,300. So, you know, even if you take out the BSc students, you're probably looking around 600 to 700 learners at any one time. That's a very challenging system when there's a tension and a dilemma. But what we did was really early on is that every apprentice who was, so over 600, was offered a wellbeing one-to-one. So that meant somebody had a face-to-face and offered, and I'm really pleased that in effect 95% of apprentices took that up. And actually really important one is to check how they were, but also importantly to check and identify, and out of that to learn and to close the loop. We've actually undertaken a number of supportive sessions to find out about and learners to look at some of the cultural work specifically about that, and also to be very open, we have instigated some employee relations disciplinary investigations as well. So the experience, while very difficult and challenging, has allowed us to do that. We have been able to award the contract with MediPro, and by the end of December, and I touch wood only because COVID, and I always get slightly nervous when I'm saying the new variant, but actually we've been able to have individual meetings again, which is their transfer of learning. So that would be really important there about the communication engagement, and that means that people are able to move forward. What's really pleasing in all of those, that we've had another 34 who've completed their entire program, and we're looking at around 70% who sit in the merit or distinction mark when they pass. So actually overall, the clinical standard and the quality, the learner effort is triangulated to say really, really powerful within those as well. Now, the robust action plan within there's two things, and one, there is a trust board conversation through our workforce committee on there. How did we not know? We have to be very open in that, because it comes back to, and I forget the colleague who asked the question, but data and effectiveness, and I've linked the two together in here is, and with any organization, when you have a lot of, I say, red beacons flashing, is which one do you pay attention to? So first of all, you'd make all the beacons red to flash, but if there's lots, how do you then make a different kind of escalation? So how did we not know? And if we did know, were we sensitive enough to it? So that's a very searching question, and one that from we've started phase one, but there's a wider conversation at our workforce committee in the new year. The second bit within there is about being very specific in the monitoring around learners and incidents with learners. And actually, what is that telling us? So we've recommenced our raising concerns forum, and this is very much about the triangulation of information. That word can be overused, but in essence is, if one data set, two data set, three data set is saying something, what actually is it really saying, and how local can you get that to be able to understand? Now, the robust action plan in one started with the reactive bit, which was meet the learners, talk to the learners, find out if there's gaps, let's deal with them, let's be very open in that. The second bit, and we'll be starting that in January, is around what I describe as the learner voice. So actually, from what people have told us, what are we now going to do with it? And that's very much about how learners feel. And look, I'm gonna say that the bit that Ofsted highlighted is we're taking action, but it's yet to be embedded and show. We have to acknowledge, and I know Chair very kindly was talking about just explaining a bit more about the cases and stuff. We are not there, and when our CEO was talking about things will get a bit worse, you know, we are still finding, we're still getting into root cause, because as people feel more comfortable to speak up, you expect to find some things, and I guess we've not normalized that, because it's very wrong to normalize it, but we view this as really part of our journey. If we're going to fix it properly, you have to accept that you're gonna find some things out about your own organization as well. But very much the action plan is really around the culture, it's around the nuance of learners. So the experience the learners may have in terms of workplace coping mechanisms, that's a posh word for saying how people refer to banter in the workplace, actually really distinguishing that about how learners feel included or not included, about small terminology and language. I think when we boil down to the hard-hitting findings and case management, so I'll pick that up in that same question, you know, people have been dismissed because of the actions that we found, people have been on warnings, people have been retrained, people have been demoted. So when we talk about impact actions, we have What I'd want to do though is for everybody, it's for the same that we say internally as well. A lot of the issues and a lot of the things, they're really the high-end examples. This is not every case and this is not every person. A lot of these are around, and you have a number of people who you want to change and stop behavior. They're not at the end which says that, and the CQC used the term sexual predatory behavior. That is the top end in a small number of cases. I don't mean that's acceptable, by the way. I'm just saying it's not every case and it's not every person, but it is very much in the bit around the culture and about the behavior, about the conversations, about values, and very much about the civility in the workplace, as I would describe it, and how incivility and behaviors drive a culture of what may be normalized. It's almost in part, some of it is generational. I'm 23 years into the ambulance service, and actually when I look back at what was done when I first started in 1998 to where we are now, the fault would be if you didn't modernize and change with time. What you can't do is turn back the clock 25 years ago to say, you can make an opinion, you can see. But actually, what I've tried to do when I've been speaking to my leadership team is, if you follow through evolution of society and you look at societal benchmarks and acceptance, plus also about morals, plus behaviors, plus values, that's what comes together in terms of it. So that's a really big piece of work within there. And the robust plan is recognizing, raising, dealing, and that's the journey we're on. And you can see some of that in the amount of employee relation casework that we have. So we still have 99 cases open, and they no sooner than we close some historic ones, we will get more, because we are doing that diving down. So I think that's really important. The other bit is we're working with Health Education East of England, and that's almost the independent and the quality element that goes with the Ofsted plan to give a level of assurance and independence, but also importantly expertise and progression as well. And the chair made some very, very kind and supportive comments around recognizing the journey, and that's exactly where, almost being in a, it used to be called Special Measures Trust, but a recovery support program trust. The key bit here is, how do you build that support around, because no one wants to be in the position, therefore how do you build it in a supportive way? So hopefully that answers a couple of the questions within there. I think the ethnicity and other data I just wanted to pick on from a question is, we absolutely do, and we do monitor, particularly as part of our workforce race equality standards and disability standards as well, but also important when it comes to really understanding gender with regards to the impact of some of the cultural work. And we're now tipping over kind of 2,000 interventions of some description with individuals, teams over the last 18 months. That's really significant. And what we have seen in some of our data is sexual harassment from, because typically people think it's male to female. Actually, we've now seen it in reverse, where males are raising concerns about harassment. So this is the whole picture of really kind of working through and surfacing through that as well. Going to touch on to the CQC, if that's all right, because I think there's a bit of a linkage into that, and I was just trying to narrate through. So you're right, so we are making real progress in the CQC, and there are absolutely some challenges in there, and some of those are I would dare draw colleagues' attention to is some of the embedding and sustaining actions. So we can all write a policy, we can measure against the policy, but it's making sure that, particularly in the legacy casework, that we've really not just reactive, but we're learning from it and it's embedded, and that will take some time. And that will take some time because we've now got a new Director of People Services, so they have to come in and they have to review where we are. We've got the culture and legacy work that's still ongoing, and a new culture director starting in April. So some timing and sequencing says you need to get the right people in, which our CEO has been able to recruit through a really good process to get the right people to help us shape that as well. So actually, while we can react and respond, some of that embedding, sustaining in those areas will take some time. And I think it comes back to would we want to go slightly faster in some? Absolutely. What we don't want to do though is we don't want to rush at a point where we then lose the ability to do it. The other bit, it's also important, because I know we talk about our frontline staff, our control room staff, and our volunteers and our patient transport staff. it's also really important to acknowledge that in terms of the nature, intensity and severity of some of the cases, it does have a psychological well-being impact on some of our HR teams as well, because exposure to a number of cases can be very difficult. So I think in terms of the bit I would draw on that one is very much about that longer term action and sustainability, particularly around the culture and the casework elements that go within there. Progress is making, but it's embedding and sustaining. Again, linked to people and how people feel. If I touch on body-worn video cameras, absolutely. You know, the cost of absence and the cost of impact, the cost of personal is really difficult, because we can quantify it, and absolutely we've quantified it through RIDDOR and days lost as well. But you know, hundreds of thousands of pounds doesn't take into account actually how people are, their ability to return to the workplace, their ability to undertake. And we've seen some really difficult cases, particularly in where people have not been able to continue their career through concern, PTSD as well. And we will try to support colleagues in redeployment. But I think we're at a stage where our staff are generally, because there's always a nervousness in terms of whether we're watching it. We're absolutely not. You know, the mechanism of the body-worn video cameras is staff-led, staff-activated. So, you know, it is maintained only for as long as required. But we're looking to be rolling them out across the trust by the end of January. We're just working through the fit in the systems that go with it, but it would give everybody access to body-worn video cameras who wishes to take them. We're not mandating them at the moment because it has to be a personal choice. There is a level of usage which is about deterrent, i.e. it's physical deterrent. And there is also, if something were to happen, the ability to be able to produce evidence to that, but it's very much about lead. That's going to be backed up and worked through with regards to in-vehicle recording within our ambulances as well. The other bit that we're also doing is we are also refocusing in terms of a national refresh on our Don't Choose to Abuse campaign. You know, because put that in the balance of everything, losing a person, losing a clinical colleague would mean, you know, that is one half of an ambulance that's not available for 3 days a week on average. The other bit is also that violence and aggression in verbal terms, so physical is one, but actually verbal aggression. And we know that some of it is, I think, a result of some of the delays, and you know, we have to accept that. But again, for the individual clinician, that is not, that, you know, they're not delaying. But we do get a lot of verbal aggression as well through our call centre, through our 999 call handlers as well. And it is, you know, it is very relentless for our call handlers in terms of the amount of 999 calls take as well. But hopefully gives you an insight into there as well. I think the question about community level is really important, actually, and I'll probably, without trying to do either a disservice, if I was to pick up the end of life conversation as well, because I think the reason I phrase it is having a conversation about topics that perhaps people wouldn't normally. So, you know, I think end of life and where people are ending their life is still a conversation to be had. I think it is still something that as a society we perhaps have started to acknowledge and started to bring in, I guess, debate about right to die and personal choice, but actually there's still a conversation to be had. There's also a reality that I think we would find that when an event happens, it's still really scary, and therefore people will phone an ambulance, because actually, you know, it's okay to talk about leading up to death, but if somebody were to die, it's still a very difficult thing at that moment in time. I think in terms of would it help and conversations, and this is where, again, linking at community level and very practical bits, absolutely, because do I think we take people into hospital who don't need to go? Yes. Do I think our ambulance staff would say the same? Yes. Do I think anyone does it deliberately? Of course not. And I think some of that's about the confidence, some of that's about training, some of that's about the advice, some of it is about advanced care planning, some of it's also about respect forms. Also for us, and the conversations we've been having as well, is that you know, our clinicians, our paramedics will look to not commence or to terminate resuscitation attempts, and there is a conversation there about how much of those could be discussed or pre-discussed in describing or working through a end of life, you know, where do I feel as a person I want to end. So probably we could debate that for the rest of the session, but I hope in the spirit of answering the question that I think, you know, is it there? No. Do I think it's a focus of everybody? Absolutely it is, because I think, you know, we would agree. Hospitals will do the best they can, but that best they can doesn't mean it's the best that it should be, and it's not through anyone's fault. It's about the conversations that we have as well. I think in terms of community, you're right, we've got some really you know, important things, and I'll link it into hospital handover as well. So in hospital handovers, my view on hospital handover that we describe is these are a symptom of something. You know, nobody starts the day to cause hospital handovers and for us not to be able to respond, but very much that these really around pressures or symptoms of something. And, you know, social care, the ability to discharge patients, the ability to maintain a flow of patients, the balance between elective emergency care and urgent care that goes within that is a real challenge and dilemma. Workforce becomes one of those. But the other key bit, I think, and the community conversation is, what does care look like? So how can care be delivered closer to home? And actually, if I'm a member of the public, what does that really mean? And actually, in terms of an insight for us and how we operate as well, to be fair, our clinicians are no different. If a pathway is very difficult to access, actually our clinicians won't do it either. We're deep down, I think we're all relatively just make it as easy as you can for me, and I'll try and do something, make it, I have to phone 15 numbers, give some special passwords, do what, but it becomes very, very difficult to do it. And our clinicians are no different. You know, our paramedics, our technicians, our emergency support workers, our control room clinicians, unless we've subspecialized, we are all generic emergency clinicians. Therefore, the ability to have conversations about accessing pathways of care really important. And I think at the community level, it's what's available. It's also an element of prevention as well. And I think prevention is an area that we need to look at. Vulnerability, we need to look at how we use the public health data. We know that from an ambulance service perspective, age and deprivation are the two big drivers for access or need for the ambulance service, and therefore within there has to be an opportunity with regards to how at a community level. Just as an example, with regards to some of the improvement plans, particularly in the systems here about hospital handover, so I'll bring that, you know, that's sparking those conversations about how do we link the services, how do we link resources. So if resources are very difficult or challenging, how do you actually draw those together that makes a difference? So we can all say workforce is difficult because we don't have enough, so therefore could we work smarter together? We've got a good kind of plan formulated within here about access to community services, care close to the home, and starting to use data, and we're replicating that as a conversation in other areas as well, because it does really make a difference as well. The other bit that we're doing within there is absolutely about the 2-hour urgent response, so the community response, and also activities and around mental health. So we have limited hours of mental health. So we do have option 2 111 here, first response, really good. The physical response, you know, it's always difficult, because where do you place it? Because the balance between physical resourcing is how many patients you could see and work through, but actually there is absolutely a benefit of, in the right area, the ability to have a physical rapid response rather than safety of an emergency department. So that is work that we are looking at, and we are trying to work with our mental health trust, because again, it's the sharing of the workforce within there, and also the dynamic of ambulance, mental health, and also police as well, around the use of section 136. And there are 2 models, which is health and mental health, and health and police, each of them very slightly differently, but actually where's the best and the most evaluated method that sits within that as well. So other bit, staff turnover, and just to talk about that. So I would say in Cambridgeshire and Peterborough particularly, there is an element of stability. Staff turnover, I think in October, was only 4 across the whole of Cambs and Peterborough, so relatively stable. I think what we had noticed is that there is a shift and a move for our paramedics to move to primary care. And I think we have to acknowledge that that's that workforce gap, and we are seeing some staff turnover in there as well. So it's that working with primary care, working differently, but also continued recruitment. Cambridgeshire itself technically, Cambridgeshire and Peterborough technically has an over-establishment. It doesn't feel like that when you factor in some of those staff are still in training, and some of those staff would fall within the people who are not at work as well. But actually, when we look at it, that's the areas. Nationally, all ambulance trust performance is under pressure and under challenge. There is a link, and be very clear, there's a link between staffing levels, how many ambulances you can produce, the amount of delays and the demand that you have within there as well. And we know that for us in East of England, we are probably more challenged with our category 1 response across all areas than some other trusts in the country. For category 2, while all trusts are more challenged, we are probably more towards the middle of the pack. But for C1, we definitely know we are trying to work on some improvements within there. And picking up the question on co-responders, the co-responders is one way of us supporting that, and that can be through fire and rescue services and about the response that they make, and also the other areas, particularly around some other volunteers as we progress forward as well. And typically, just as an indication, across the whole East of England, our volunteer responders would give around 38,000 hours a month to the communities, which is a significant amount of support responding to falls, cardiac arrest. So really significant volunteering within those as well. If I touch on, just going to bring on to COVID. So I think we talked about the offices in the hybrid approach. That was all okay until Plan B. So I'm reviewing Plan B tomorrow, what that may mean for us as an ambulance service. Clearly, there are roles. So we are able to facilitate some working from home, even from our clinicians. So particularly, I can actually on my laptop, I can triage patients if I needed to. So I can do that. I can't physically respond, but that's something that we're working through now, based around the new rules and regulations as we move into as well. REAP 4, absolutely, since July. REAP 4 is probably designed to be in for perhaps a week, maybe 2 weeks. It's not designed to be in for months and months and months. And in part, some of it is that it is designed to deal with a spike, whether that be demand or whether it be absence. And clearly, it doesn't become sustainable, because in order to do that, you have to turn a number of things off, or you have to balance priorities. What we have done as an organisation is we are partway through our business impact assessment of sustainability, and we are going to have to turn some things on, because you can't pause things like statutory mandatory training for staff. You have to make a balance on this. So that's the activity that we're doing, and it's very much a hot topic and an oversight for the trust board as well. I think I've probably mentioned acute hospital and handover, so I wasn't going to, and I know there's a question, but hopefully I've given a flavour of that, so I wasn't going to necessarily go into any more of those. Private ambulance services. So just to give an indication across the whole trust, we would probably have around 30 to 35 private ambulance services a day. We would typically put out around 330 to 340 ambulances a day. So 10% under of our resourcing, and that is spread across the whole organisation. So it's not concentrated in one area, but very much spread about either pre-planned shifts, or if needs be, about moving dynamically on the day for any shortfalls as well. Just going to touch on mental health, because I think that's and I think, and forgive me if I've missed anything, colleagues, it will soon be your time to jump in and tell me, but probably the right place for me to talk about kind of staff and patients, because this is we are patient focused, but in order to do that, if we put our patients first, you have to put our staff kind of always next to that. And mental health, it has been very difficult. We've been tracking for a while that we know that mental health, stress, anxiety is our top reason for absence across all staff groups, followed by COVID and then musculoskeletal. And for us is really, really important. If we look at some of our long-term learning, you know, we are in a bit of that cycle. So continued pressure over 2 years when you look at summer, spring, COVID, etc. And so we've spent a long time with regards to increasing access for support services. We're making use of the wellbeing hubs. We've reintroducing a more sizable wellbeing team as well as occupational health. We have our employees assistance program, a 24-hour mental health crisis line. We're fully fully on board with the Mind Blue Light program. We know that we are also talking through wellbeing champions. We're training in trauma risk management and a number of things that go within all of those to really bolster the offering. Is it enough? I think we can always do more, but actually some of it is making sure that we have a range of things that are really accessible. We've also been able to undo some of our legacy things that, you know, whether they were put in for the right reasons, you know, kind of we could debate, but actually things like removing caps on counselling sessions. So there was no caps. Originally it was 6. Actually, there's no cap on those now. So there's a number of things within there that we're doing as well. We've seen and we've been able to support using the Sir Tom Captain More money in wellbeing gardens and start very popular within those. So really a number of bits. And it does link back to some of the cultural work and activities about a place to work, about openness, about honesty and about civility. Chair, thank you very much. And I apologise if I have missed anyone's comments or questions. And I know I've probably talked for a significant amount of time, which I do apologise for that. But obviously you gave me a huge range of questions, which were very helpful. But I'll pass back to you. Thank you.
Thank you. First of all, no apology needed whatsoever. We thank you for the comprehensive replies that you've given. And it's clearly the purpose of this exchange to hear those answers. So thank you so much for being so diligent, but also so thoughtful in what you said. As with the other reports we've heard this afternoon, this will be written up. We hope the conclusions will help you further in your reflections, as well as for us going on our record. Formally, the committee is asked to note and comment on the report as on all the reports this afternoon. Everyone happy with that? Lots of nods, so that is agreed. Before I close the meeting, and thank you very much again, Marcus, really appreciate it. Just to say, you've taken the trouble to come and the quality of your answers has been really excellent. Thank you again. Before I close the meeting, first of all, thank you to Councillor Garvey and Councillor Wood, who've been assiduous as well, being with us throughout the afternoon session. We are anxious to be able to meet together physically, not just in hybrid form. When new COVID advice came in, it was too late for us to alter the venue for this afternoon, but we are very minded to enable meetings which can have all of the members, district, city and county together physically. So thank you very much for bearing with us this afternoon, but please accept that we will make best efforts to make sure that everyone can participate in equal fashion. Just for all the members, county members, in your diaries, you've got our next meeting is the 13th of January at 10 and all day. We anticipate having a scrutiny session with the Integrated Care and Support System key actors in the afternoon, really important. But we also want to prepare for that as adequately as possible, because it's a really, really important exchange. One of the possibilities at the moment is that we use the morning time we've got in the diary to either as development time or to deal with a report that we could actually formally agree. We're just looking at that at the moment, so please keep the 13th of January in the morning free in your diaries. As soon as we determine that, which we hope will be as soon as next week, we will then send an email out to everyone. Clearly, if we don't need to use your time, we won't. We'll only do it if necessary. But at the moment, please keep all day on the 13th of January 3. I think it's been a fantastic meeting. Thank you everyone for the contributions you've made, and keeping up the concentration levels and respecting all the rules. Thank you to all our officer friends who are both here and who have been with us during the course of the day. And the meeting I now formally declare closed. We'll be back.